Thank you.
Thanks. So welcome everybody to this afternoon's Angus IGB meeting. I hope everybody's keeping well. So I think just to say, in light of the increasing COVID-19 figures across Scotland, I'd like to highlight again the very challenging situation that the HSCP third sector and care home colleagues are working within at the minute, and commend everybody for your continuing dedication to providing excellent health and social care services across Angus. I think it's a very important still to be acknowledging that at the start of all our IGB meetings. Just to say at the start, I believe this is Charlie Sinclair's last meeting as he's moving on to a new role. So Charlie, I'd like to thank you very much for all of your input for Angus IGB, and on behalf of us all to wish you all the very best for the future. And I also want to give a very warm welcome to Gail Smith in her capacity as the Chief Officer now of the Angus HSCP, and we do have a paper on this later on in the agenda, but I wanted to highlight Gail's appointment to the substantive post and to offer our congratulations to her, and that we all in the IGB very much look forward to continuing to work with you and all of your team into the future. So we've got a fairly big agenda today, and I know everybody will have had the chance to read the papers in advance. So if we just move on to item 2, which is our item 1, apologies.
Chair, there's no apologies intimated.
Great, thank you. And item 2, declarations of interest. Councillor Bell.
Thanks, Chair. Just my usual one, as a non-executive director of Public Health Scotland, for which I have a specific exclusion, but just to keep the record straight, it's non-financial, and I will stay in. Thank you.
Thank you. And do we have any others? No, not seeing any other hands. No.
Peter Burke's got his hand up there.
Sorry, so I'm not seeing all hands. So if you maybe switch on your camera as well, if you as well as raising your hand, and Karen, you can maybe keep me right if anybody else has got their hand up. So Peter.
Yeah, thanks. Yeah, items 9 and 10 have a non-financial interest.
That's great, thank you. Any other declarations of interest? No.
Yeah. Sorry.
Councillor Speed.
Yeah, just the same as Peter. I have a non-financial interest in items 9 and 10.
That's great, thanks. Any others?
Chair, sorry, before we go on, can I just ask Peter and Councillor Speed what their interest is? Is it as a carer?
Yeah, it is for me, Karen. Yeah.
And it's the unpaid carers rep from me, Karen, a carers rep, on behalf of carers.
Thank you.
Okay, we move on to item 3, which is the minutes. And first of all, the minute of the meeting on the 23rd of June. Thank you very much to Karen for that minute. Are we happy to approve this minute as a correct record? Yep, thank you. And we'll move on to item 3B, which is the action log. Gail, will I hand over to you for that one?
Yes, thank you, Chair. The action log I'd like to draw attention to particularly are the 3 areas of overdue. The rest, I think I would commend the team for being on target and complete with the other actions. Page 16, 14th of December was the mental health and wellbeing strategy draft. The update in the 4th of August was the most recent update that we've received. So I've noted that in the action points. And then the other is still regarding the Angus IGB Strategic Financial Plan update. That was due to the impact of COVID-19. We extended the deadline until August 21. Again, that is part of the financial report that was recorded in August 21, but still overdue at this stage. And the next point, item 4, was the demographic issues addressed in April 2021. And again, that's overdue for the strategic financial plan.
Okay, thanks for that, Gail. Do we have any questions for Gail on that? No. Okay, we're happy to note that action log then. Thank you. And we move on to item 3C, which is the minute of the Audit Committee, and this is for noting. Are we happy to note these minutes? Yep. Okay, so we move on to, just losing where I am here. Item 4A, which is, well, section 4 is appointments, and item 4A is the appointment of Chief Officer. And we are being asked to note the appointment of Gail Smith as Chief Officer. And as a fairly self-explanatory paper here, but as I said at the start, on behalf of the IGB, I would like to congratulate Gail on her appointment. Gail has, of course, been leading the HSCP through one of, if not the most challenging periods that we've seen in terms of delivering health and social care. And she's very much done this with compassion and strength. And very much delighted that we will be continuing to work together. So congratulations again. Bob?
Yes, I would just like to echo your sentiments there and add my congratulations as well. I think we've got a first-class officer, if not the best in Scotland, with Gail. She's been doing the job for long enough. She knows it inside out. So very lucky to have her, and well, congratulations again. Well done.
Thank you, Bob.
Can I just thank you all
Yes.
for your support and your congratulations, and actually I would like to commend the panel for how they shared the positive story with me, and the success. I just thought that was also done with compassion and thought, and was very much appreciated by me. Thank you.
Thanks, Gail. So are we happy to note that report then? Yep. Okay. And moving on to item 4B, which is also under appointments, and this is appointment of a board member to the Audit Committee. I'm not sure if I'm to hand over to Sandy for this one, but I believe we need a new member for the Audit Committee. Sandy, do you want to take this one?
Yeah, I will very briefly. Thanks, Chair. Yeah, we are looking for a replacement for Graham Martin, who was on the Audit Committee previously. Graham kind of stepped down from the IGB a wee while ago. Now, we noted that we needed an appointment filled at the last meeting, and today we're really just looking for volunteers to kind of step forward to offer to take on that role.
Okay, thanks, Sandy. And before I request any volunteers, Councillor Bell, did you want to come in?
Yes, I'd just like to dive in there. We have had a volunteer offline in that Hayley Mearns from VAA has indicated an interest, and I would be hugely supportive of that. I think having a staff side rep on the Audit Committee and a third sector rep as well gives us a really rounded, holistic approach to audit and the work that we do, and I would certainly be happy to support Hayley's appointment to the board's Audit Committee.
That's great, thank you, Councillor Bell. And luckily, Hayley.
Yeah, just to confirm, I would like to still volunteer to be on the Audit Committee. So yeah, if they are happy to have me, I would be happy to join.
That's great, thanks very much, Hayley. So are we happy to appoint Hayley Mearns to the Audit Committee? Yep. Okay, thanks very much, and thanks very much for that, Hayley.
Chair, can I just quickly mention, and Charlie will know this anyway, Charlie Sinclair is also a member of the Audit Committee. So having just filled Graham's vacated post with Hayley, thank you for offering to fill that role. We'll have to deal with the same issue again at the next IGB meeting. So we'll do the same thing and try and assess interest before then. Thank you.
Okay, thanks. Councillor Bell?
Yeah, thanks, Chair. Could I just come in and ask Sandy if there are any parameters around that appointment? Does that have to be from NHS Tayside?
No, there are no parameters. Charlie was allowed to be a member of the Audit Committee because he was an IGB board member. So any IGB board member can take on that vacant role, with the exception of the chair and the vice chair.
Okay. Thanks for that clarification, Sandy. And as you said, we'll see this situation again at the next IGB. Okay, so moving on now to item 5, which is the finance report. And I think we've got a number of recommendations in here, and I'll hand over to Sandy to take us through some of the key elements of the paper and the recommendations as well.
Thank you, Chair. Yeah, just on the subject of recommendations, I'm not quite sure how this has happened. I think recommendation 3 and 4 should actually all be one sentence. So when you come to read them, it will make much more sense as one sentence. This is our regular finance report. It is the first time we've done it in a new kind of format, reflecting the overall changes and developments in IGB report format. So it is slightly different. And we're hopeful that it's still relatively accessible, and we'll try and, as we go through the next month or two, and continue to make it easy to access, particularly when it comes to referencing different parts of the report. The main kind of summary outcome is at the moment is set out actually on the first page of the report, under section 2, where we are saying at this point in the year, which is very, very early in the financial year, we are projecting that the IGB will have an underspend at the end of this year. We're reckoning it could be about £2 million. There are many assumptions built into that. Principally, we are assuming a reliance on a significant level of COVID funding from the government, which we have got in reserves, so that should all be okay. And that's set out later on in the report. So that's the kind of headline position at the bottom of page 30 in section 2. We are projecting an underspend of about £2 million. Now, some of that is probably for reasons that were factors last year. There is some, while we have COVID responses going on, there are other bits of activity that are probably a bit less than they might otherwise be, including project type work. But there are also a level of vacancies in some of our services that eventually we will fill, but some of these are appreciated have been ongoing for a wee while. So that's the kind of headline position. In terms of, I'm just going to pick out a few points for the board. On page 33, under the adult services section, we note that we still are doing a lot of work on key provider support arrangements. That's the arrangements where we support the independent sector and the third sector for costs associated with COVID. A lot of those arrangements have continued into this financial year. They've got varying timelines on them. That's incurring quite a lot of costs. It is funded by the Scottish Government, but it is ongoing for now, and certainly some of them are ongoing to the end of September. So we've got that as a factor. It's still a big piece of work for us. Again, in a similar section, and tying back to things that are in the action points, we have still an unresolved issue about mapping out the financial implications of the Carers Act and our overall plans regarding carers funding. So that's not being lost. We know we didn't resolve that earlier on in this calendar year, and it's kind of been brought forward in the action points, and we're noting in the finance report. Page 34 of the report, where we're talking about the financial impact of COVID-19, we are seeing an ongoing impact. As I say, it's coverable. You know, we have got reserves to deal with this. That's exactly what those reserves are intended to do. We set out the main areas of spending. These are kind of a mix of things that we saw in the first year of our COVID responses and things that are coming through as part of our overall remobilisation. What, of course, is harder to pin down in terms of planning and longer term planning is the longer term financial impact of COVID responses, or the impact of COVID on the overall system. So we'll have to see how we go with that. Further on in the report, on page 35, there is a section setting out where we are with progress with some of our strategic financial planned interventions. This is obviously an important issue for the IGB. And you can see in that table there, there is a mixed picture. Some things have been delivered and are resolved. Some things are on target to be achieved, and an important one of those was our revised care home commissioning, where we were moving care from care homes into home care. And some things are behind schedule and are forecasted to run behind schedule this year. Now, if you're able to recover that timeline, that will all be well and good. But if some of that running behind schedule is indicative of a problem there, we all, in terms of recurring delivery, we have a more significant problem in terms of our overall financial plan. So a table like that will appear in future IGB reports until things are more resolved later on in the year. And the final point I want to flag up is in Appendix 3, where we are, and I've just gone too far forward. In Appendix 3, we are setting out the position regarding Igb reserves. Now, Igb reserves, the board will know, are relatively high. We have a whole range of individual reserves within that. And within this paper, under the heading of Strategic Plan Reserve, we're recommending putting an additional £600,000 or £670,000 into that Strategic Plan Reserve from one of our other reserves. The Igb Strategic Planning Group have been overseeing that Strategic Planning Reserve, and the funding from that, as far as I can tell, and I'm sure the SPG would agree, it looks like it's contributing significantly to our ability to support the delivery of the strategic plan, whether that's in terms of providing project management capacity, supporting technology investments, equipment investments, and a range of other things like recruitment and retention. So the recommendation from the SPG, and they discussed this at the start of this month, was to insert extra funding in there, because a lot of that funding has now been allocated. And I think that would feel to me to be very consistent with us looking to deliver our strategic plan, or supporting things that would deliver our strategic plan. So, Chair, that's the main points. Always important to keep an eye on things like our risk list, particularly in the context of our development session this morning, and also just keeping an eye on the governance issues which are set out in the fourth appendix. Happy to take any questions.
That's great. Thanks very much, Sandy. Do we have any questions? Councillor Miles.
Yes, Chair. Thank you, Sandy, and again, well done for achieving financial sustainability and keeping our reserves high. But this is where the danger lies. I know many other IGBs across Scotland are overspent and don't have this reserves. Are we in any danger that the government will say, well, OK, you've plenty of reserves there, you've underspent, we'll reduce the amount of money that's going to you through the COVID? Because I think that would be totally wrong, but just is there any danger there?
Okay, thanks, Councillor Miles. I think there is a kind of a mixed picture with regard to that. So there's two kind of different things going on. As we all know, with regard to COVID, there are some time-limited costs, and there's some costs that may continue, for quite a long time. We have been either fortunate or well placed to help contain some of the COVID costs. It is possible that the government will review the level of COVID funding that we have in due course as we go through this year. And I think that, I suppose in my mind, we are doing the things that we need to do to help support our COVID recovery plan, our remobilisation plan. There's only so far we can go in recruiting staff, because we have we're always constrained by our long-term position and, of course, our ability to actually fill vacancies. And the government have set a series of guidelines of costs that they expect to come through and be attributed to COVID. And they are things that we've seen in the last year and things that the government are reapproving this year. So I think we have flexibility to kind of deliver our COVID mobilisation within the funding available. The government are kind of monitoring that. But I think there is a possibility, and I think in my mind it's probably an understandable possibility, that if the funding that the government put in very quickly and promptly just proved to be a bit more than we need, they may well review that in terms of COVID going forward. However, COVID is just one reserve within the IGB, and there are many others that's set out in the third appendix. We are not unique in IGBs across Scotland in having bigger reserves this year than we've ever had before across a range of headings. And I think the government know why these reserves have gone up, and it's partly to do with the way the government allocated funding last year. Again, not unique to Angus, it happened across Scotland. So I think the government will keep an eye on these reserves. A number of programmes have got kind of backed up across Scotland during the period of COVID. It's hard I honestly don't quite know how that'll pan out, Councillor Miles, in terms of how governments may adjust temporary funding. What I would say though is I've got no reason to think that any of our recurring funding would have any reason to be affected by the factors that they described. So I think maybe some reserves might be affected, but I've got no reason to think recurring funding would be affected.
Thank you. Hope you're right.
Okay, do we have any other questions for Sandy?
Elaine Henry had her hand up, Chair.
Elaine?
Yes, it is a question for Sandy. The part of our budget as well is the services hosted by the other two IGBs, and it was just to ask, is there any sign of a trend of less spending in those areas? I'm just thinking that a lot of the services like podiatry weren't able to do face-to-face dental services. So do we almost have a built-in promise of more spending to come because does our overspend look slightly better in those areas because we haven't seen the patients to spend the money? So is there potentially a lag of more demand as we remobilise? And just, is there a trend of these numbers going up or down?
Thanks, Elaine. Certainly, in terms of the word trend, I don't think I can see a trend yet, and we haven't kind of been informed of a trend. But it's so far, it is possible that kind of trend might emerge. And you're right to pick out one or two services where there may be cases have got backed up in the system. For example, in podiatry. There equally will be instances across these services where costs have been higher to do with COVID over the last year. So some costs may come down as others go up. However, at the moment, my guess would be that if there was a series of backed up caseloads in, for example, podiatry, COVID funding would probably be suitable to be applied to that. So the financial cost of dealing with the backlog would probably be attributable to COVID funding that is available during this year. So there's possibly a trend that might emerge, but if it's to do with COVID, the COVID funding would help offset that.
Okay, Councillor Bell.
Thank you, Chair. Yeah, I just wondered if you could give us a little more detail on any movement on both the large hospital set-aside discussion, Sandy, and the financial structures support through Angus Council, which is the last row on page 41, the first and the last row in the tables, please.
Okay, so there are a couple of sides to the large hospital set-aside issue, and I'm going to hark back, and it's easy for me because I've got it familiar with it in my head, to a paper we shared with the IGB in December. The paper that we shared in December did two things. It looked back the way and looked at some historic issues, but it also looked forward. The forward look was also updated. I think Jill had a paper at either the last IGB or the one before, setting out where we were going forward. Although that work is maybe will also be kind of hampered with people dealing with COVID responses, I don't think anything fundamentally has changed in terms of development ideas compared with what Jill set out in the paper, either at the April or June meetings. In terms of the historic issues, those are not resolved yet. They are as they were, and we haven't been able to apply much time to dealing with that over the last few months. So they're still on the kind of list of things to get back to, but the forward-looking work is pretty much as per the last IGB paper. I think it was called Whole System Pathways. I have a feeling it was in June. The second item you asked about there, Councillor Bell, was about finance support from Angus Council. That is slowly, that is progressing, I feel, which is good news, definitely. And I wouldn't have been able to say that 6 months ago. It is progressing, not particularly quickly. Again, that's to do with one or two complications of getting things kind of sorted out into the right places. But I am hopeful that that feels like it's progressing gradually. And I would hope to be able to say that we have actually managed to resolve that by the time we get to the next IGB meeting. Okay, thank you.
Okay, we've got any further questions for Sandy? No. Okay, so in terms of recommendations for this paper, as Sandy's alluded to, there's a number in terms of noting some of the content, but also supporting the proposed reallocation of £672,000 of reserves from the IGB's financial planning reserve. Are we happy with these recommendations? Okay, thank you very much. So we'll move on now to item 6 on the agenda, which is the COVID report, COVID-19 response. Okay, is this Jill going to take this one, or Gail?
Yes, Jill's going to update you here, but I think it was important that we brought along a position paper regarding our response, because we're very much still in the pandemic. I'm sure you're all reading and listening to the news. So I think it's really important that we keep this on the agenda and bring relevant reports when required, Chair. Jill?
Thanks, Gail, and thank you, Chair. I'm not going to go through the paper in detail, Chair, because it is a lengthy paper with quite a detailed update of our current position. I think just a couple of things to highlight. Gail's already mentioned the current position, and as we are beginning again to see that increased community transmission across Scotland and indeed in Tayside is reflected in our numbers. I think today Tayside was sitting at 279 per 100,000. We are continuing to have inpatients, and what we're not clear about at the moment is what the impact of this current increase in community transmission will turn into in terms of hospital admissions. It's usually a couple of weeks down the line before we start to see any impact within the acute setting. However, I think it is worth noting that in terms of capacity within the critical care and the demand, there has been a fairly static number of patients within COVID ICU and COVID HDU over the last few months. Obviously, as we're heading into winter, it's in the forefront of our mind in terms of supporting the services throughout the next few months. We are beginning to see pressures again, I think it's fair to say, in some of the services, and in particular quite an increase in paediatric attendances with other respiratory viruses as well. So our winter planning is paramount alongside the work that we're doing with COVID, parallel to trying to remobilise the services as we see fit and safe. The complexity and acuity of patients is also increasing. So what we are seeing coming through the system from both a primary and community care perspective and acute is the complexity of individuals coming through the system and the level of deconditioning and the increased support that individuals are needing from a rehab perspective. And that includes from post-planned surgery as well, just in terms of that increased need for additional support. That also translates into some additional pressures on top of what we already have to provide that enablement and response team to support individuals to get them discharged from hospital and indeed prevent admissions as well. So members will be aware that we have had a significant increase in our personal care hours at home, and that continues. But what we are also seeing, and George might want to comment, is the shift in terms of the types of care packages that people are actually needing now. The occupancy within our community hospitals remains low from an MFE perspective, and we're currently working on remobilisation plan 4. So I think it was the April IGB, we brought remobilisation plan 3. We've now been asked to review remobilisation plan and submit an update by the end of September. Going into the winter, obviously vaccinations is high on everybody's agenda, both in terms of COVID vaccinations and the associated boosters, as well as flu vaccinations as well. And we're still waiting GVCI guidance in terms of the outcome of whether we'll be able to administer concurrent flu and COVID booster vaccinations at the same time. However, the flu vaccination programme is due to start early September or mid-September. Sandy's obviously covered the financial implications of COVID, so I don't think I've got anything else, Chair, to add at this moment in time. But again, just acknowledging the pressures that the services are under and the continued commitment and dedication from all of the staff.
That's great. Thanks very much, Jill. And certainly very welcome that these reports remain on the agenda. Thank you very much for bringing this to our attention. I just before I open it up, I just had a couple of questions, if that was okay. The first one was related really to long COVID and potential for long COVID clinics. I understand there are long COVID clinics running in Dundee at the minute, and I wondered if the similar was happening in Angus or plans were underway to, what was the response to that. And the other one was really just highlighting the fairly high number of delayed discharges. And I understand there's a little narrative provided in the paper. I just wondered if there was any further narrative on that, you know, in terms of assurance for the board, in terms of that fairly high figure.
Yeah, I'll take it in that order, Chair, if that's okay. So it was remiss of me to not mention the level of delayed discharges as part of the report, and unfortunately we are continuing to see quite a high number of delayed discharges for our Angus residents who are delayed in hospital. We have had an increase, as the report articulates, around the delays in mental health services. That's a mixture of guardianship applications, which I think in a previous report we had highlighted some of the challenges around the progress with the applications, and also availability of suitable facilities within the community to support individuals in the community. I've obviously mentioned the pressures in ERT and private providers as well to provide the care at home, and certainly the health delays and the social work delays that we have. George might want to come in again around this, but the teams have been working exceptionally hard to improve that. So we do have plans in place for the individuals who are waiting on ERT at the moment. And we have had a couple of meetings with mental health now in relation to the delays. So we're identifying some work that we can do with them to support the position around mental health delays. George, I don't know if you want to come in around that just now, and then I'll pick up on the long COVID.
Yes, Chair, will I just come in? Okay, yeah, I mean, that's a pretty good summary, Jill. I think the delays are for three reasons, really. We're a bit backlogged with AWI and guardianship work, partly due to we're still catching up from the court closures, really. There was a big backlog from that. Courts were closed for a long time. We didn't consider this business. Partly due to a general increase in the amount of AWI work and some changes around review requirements from the courts. They're asking for much more frequent reviews, so that's all creating pressures on the team. We put some additional resources in the mental health officer team, but it's growing again, the work. The second one really, is, as Jill said, was about pressures on ERT. So the enablement team depends on throughput into the long-term personal care providers, and we've increased the hours there from, well, total hours from 10,300 hours per week at the start of the pandemic to 13,400 hours in 18 months, a 3,000 hour per week increase. It's massive and pretty hard to stay on top of. I don't think we might have plateaued now. I think we've been sitting at around 13,200, 13,400 for a few weeks, but the providers struggle to recruit staff quickly enough to stay ahead of demand. And then what happens is we get a bit log jammed in enablement, and we've got 17 cases waiting to go across currently. That doesn't sound like a great deal, but actually it's quite a lot to hold up things in ERT, unusually high. However, we're expecting that to loosen up a wee bit now the schools are back and staff are coming back from holidays. So I think that's been quite a big issue in the independent sector. Like everybody else, they've been deferring leave to deal with the pandemic. So that will hopefully sort things out. We are working with the providers on recruitment events as well. We've done a big survey around kind of recruitment issues. And the final one is really just about physical resources. Some of the more complex cases which are now appearing on the delayed discharge figures actually require specialist builds or very specialised complex care resources, which we often have to go down to England or much further afield and locally to identify those resources, and that's very challenging. So I think there's a combination of reasons for the numbers creeping up, and we're working on all of those things.
Thanks, George. Chair, I'll just pick up on the question around long COVID, and Alison may want to contribute to that from a clinical perspective, because it's quite an interesting topic and has generated quite a lot of conversation and discussion around what long COVID actually means and what are the implications from long COVID. So I think the service that you were referring to was the CARES model that has been set up. So there has been some discussion across all three partnerships around the longer term potential for that. And there's some further work to be done and further discussion to be had around that, because I think as the pandemic goes on longer, the long COVID is now kind of living with COVID for everybody, and we need to look at how we're actually going to support that from an infrastructure and a service perspective, and how do we mainstream some of that activity if we are going to be living with COVID for a number of years. Alison, is there anything that you want to add from a clinical perspective around that?
Well, we do have the option as GPs to refer to the care service, and we are looking across Tayside as how we support people with long COVID, which is quite a diverse range of symptoms and a diverse range of people as well. So it's not about one size fits all. There are delays at the moment in long waiting list for the outpatient assessment, so we are looking at how we support that, but also how we make sure that communication between general practice and the rehab teams is optimal. One of the ways of doing that is making sure we've got a clear pathway, which we are implementing, and we are making sure that people have access to the appropriate investigations to make sure there's not some complications of COVID. You know, people have chest x-rays and that sort of thing before they're on a waiting list for rehab, but absolutely recognising that there are delays in the system. And the people that are looking after people with COVID, a lot of our AHPs, they're also people that are busy with other aspects of healthcare, and it's trying to get the right balance across the whole system.
That's great. Thanks very much. Gail, did you want to come in? I see a few other hands up as well, but bring Gail in first.
Yeah, it was really around the planning for 21-22, the COVID booster programme. By way of reassurance, there is a COVID vaccination programme board that continues to meet across Tayside, so we've very much been planning for that autumn-winter 21-22 programme so far. And based on the current situation with the timelines, which we're waiting on formally from JCVI, we very much are looking at the flu programme beginning at the beginning of September. The start of the flu vaccination should begin with the focus on flu and the number of people being vaccinated, ideally by the end of November. And that are the timescales that we're still really working on. Particularly, we're going to focus on those of highest risk as far as possible, but it's very frustrating, Chair, that we're still waiting on the guidance at this stage.
Okay, thanks. That's very helpful. Thanks for that, Gail. Councillor Bell.
Thank you, Chair, and thanks, Jill, for this report. It's really helpful. There are just a couple of things that I wanted to pick up on one on page 44 rather, around the additional posts in integrated mental health. You mentioned a small number, but I wondered how many and how long are they in place for, if you can give me that. And I guess my anxiety is that they'll need to be extended because of the volume of work that we might have, and just to flag that up, but also around the health and well-being of our staff. And are there what are the trends around sickness absence at the moment? Because obviously things like long COVID will be affecting our workforce as well as the general population. And even if people are well enough to come back to work, I rather fear for their stamina in terms of, you know, being able to perform to the same level as they were before. And I think our sickness absence levels were maybe falsely suppressed as people rolled up their sleeves and got on with the pandemic. And are we seeing the kind of fallout from that? I really don't want anyone to be at their work when they're really ill and not able. And I know we've got policies and processes in place to support people, but that does have a knock-on effect on the rest of the staff. So it's a holistic question, I guess. How is the health of our workforce at the moment and the morale? Because they've been under so much pressure and we've had so many asks on them. I am hugely concerned about how sustainable that is for people. Thanks, Jill.
Thanks, Councillor Bell. So just in relation to the integrated mental health, and I'll comment on that specifically, but in general terms, as a partnership for some of the services that were under pressure, we, with Sandy, Charlie and Karen, etc., talked through how we could provide additional support to the teams during this quite challenging and difficult period. So that has included over recruitment to a number of different services. So integrated mental health is only one of the services where we have taken that approach to over recruit and go above our establishment at this moment in time. Obviously, from a workforce perspective, the teams have additional support and input to the team, and as service leads, heads of service, we're very conscious, and Sandy is there, that we do need to make sure that that is part of our budget planning and financial planning going forward. So it will link in with the work that George has taken forward around the workforce plans, so that we can make sure that we do have an appropriate level of workforce, but we also have an exit strategy for those areas where we have over recruited, and as we come out of the pandemic, the need might be less in those areas. We haven't recruited to them on a temporary basis, Councillor Bell. We have again taken the decision to appoint them on a permanent basis with that exit kind of strategy there. So I think a really positive, something that was supported by Sandy as Chief Finance Officer and Gail as Chief Officer, to link in with the health and wellbeing of the staff as well, because the teams are feeling supported in that way. I think from a staff morale perspective, if I was to do a temperature check, I would be saying that we're probably at a hot amber position with staff. Sickness and the recording of COVID or COVID related sickness is recorded separate to other sickness. So we can pull off information in terms of the number of people that we have off with COVID or long COVID symptoms, mobilise and planned activities. Again, we are also seeing an increase in staff going off for planned procedures, which also impacts obviously the available workforce. I think to support individuals coming back, we've got a number of different options that we have available to us to support, and that includes looking at modified duties as well, supporting individuals to work from home, just to get them back to work and to get them to a point where they are fit and healthy to undertake their substantive role. I think organisationally they have put additional funding into the wellbeing team, which has been very positively, and the staff. So they are seeing an increase in people calling the wellbeing centre for some support, which is actually a really positive thing. The staff are actually recognising the need for some additional support, and as we always do, support and encourage people to take annual leave as and when they can.
Okay, George, I saw your hand was up, it's gone down now, but Alison?
I just want to highlight the pressure on general practice at the moment, which we were having a discussion about risk this morning, and the sustainability of primary care being our biggest risk in the partnership. So as health services are remobilising, there's more routine care. People that have not maybe addressed the problems are coming to general practice. We still have COVID restrictions and the requirement to be managed using full PPE and all the usual precautions. We have workforce challenges, and we have people suffering from quite a considerable amount of mental health across the whole spectrum. So people that have never experienced anxiety and poor mental health are anxious, and they're really seeking our support. So the demand on general practice at the moment is extensive, and we are doing our best to manage that. I know myself, I've been in Brecon on Monday helping because they were short-staffed, and we are all pulling together, but the workforce is tired. I would emphasise the importance, though, of the partnership services, the extended multidisciplinary team around general practice in supporting us. So The work that we have done in getting the right model in Angus around the district nursing, the social care, the peer support, mental health integrated teams, you know, we've got the right models in place. It's just growing the workforce to support general practice at this time. So we're working hard, but by all means, if we know we're, you know, getting the type of access for care that we would like for our patients at the moment, we are working on a sort of telephone triage first that perhaps the public are frustrated with. Fully understand that, but we need to try and make sure that we're managing the risk and get to the people that need us most first, and make good use of all the other sort of mental health supports and social supports in the community that are available for people.
Thanks, Alison. Gail?
Yeah, I would like to emphasise, Chair, that the health and well-being of our workforce remains our priority. We absolutely continue to remain closely focused on the recovery of our staff, and as Jill said, encourage them to take leave. Staff are encouraged to seek support if required and look after themselves and also others where possible. And I would like to commend the heads of service, the clinical staff and the teams in continuing to do that.
Thanks, Gail. And I'll just bring in George before I bring in Councillor Speed and Peter Drury. George.
Yeah, I just want to give a special mention and dispatches to the care home staff. I think it's really important that they're not forgotten about. They've had a pretty torrid time in the last 18 months. You know, we've had our care home operational group still meeting once a week, was meeting daily at the height of the pandemic. And we've put a lot of energy into providing supports for what is a pretty traumatised staff group. They've had a real combination of dealing with outbreaks of illness, constant changes to guidance about what they should be doing, their staff becoming unwell, dealing with the thought that you might be bringing COVID into work from which people might subsequently die. That's a huge pressure. As I say, we put a lot of energy into that. I think they've also been under huge pressure in the media, not always favourably, and of course have an ongoing national police investigation to deal with as well. So I wouldn't want them not to get a mention. Hard times. 3 times tested a week as well at work. So it's tough.
Thanks, George. Elaine?
Yeah, I think it's just to reflect that, and I think also that it's not over yet for staff. I think staff are very tired. Although folk have had leave, it's probably not been as refreshing. It's not been as able to get away from it. A lot of people have been sucked into Teams meetings when they've been off, and I think absolutely just that reflection from George beautifully describes that pressure of going to your work, but you may do harm at your work. It's a very difficult place to be. I think it's not over in that I think winter this year with COVID is going to be probably the most challenging I've looked at. And I think also that scrutiny of already, while we're still trying to make new decisions and go forward, we're now starting to analyse what we did at the start of the pandemic. So I think for a lot of our leadership, people, I think that probably includes a lot of us here, that feeling of scrutiny coming behind us at a time that we're still making live decisions going forward. And that cuts it to everybody. So I think staff are tired. I think there's probably a delay of perhaps people retiring, have put it off for a bit. And I think there will be a lot of people after next spring who may think, do you know what, I might just go a bit early. And I think that could see a real seismic loss of some of our experience and support of people through the organisation. I think also just being aware that the remobilisation plan has been launched today, which is a very ambitious target to do the work that has to be done, but it hinges on staff. And I think some of those staff are being counted on several times, and everybody's got a limit. But I think people have done it with great humour and with great dignity, but they are tired.
Yeah, absolutely. Thanks for that, Elaine. It's probably still on this point. Is it Chris from Unison we've got on? It just comes up Unison Angus. So
yeah, apologies, Chair. Yeah, it's a Teams login that's used by a couple of us, so we just have a generic title. So apologies, but yeah, 99 times out of 100 here, it will be me. Good afternoon, colleagues. I just wanted to pick up just on a couple of things mentioned when you talked about staff morale and staff well-being. I think the term earlier on about a temperature check was referenced in terms of where staff are. Now, obviously, my own knowledge and experience comes from staff side with the local authority. But I'm wondering if there's an opportunity, given the clear concerns that have been raised by a number of you today, and obviously shared by me, about burnout, about morale, about overtiredness, about what's happened over the last 18 months, whether there's actually an opportunity to certainly engage with staff side, so from my point of view on the local authority, to look at where they are. A simple survey, for example, may be of use. I know that there's a short-term working group on the local authority at the moment that is looking at work-related stress, and a task and finish steering group on that. And there's a really good survey called Work Positive. That's 65 questions, takes about 15 minutes to complete. But I do think in terms of engaging with staff, it's been done in other service areas of the council that I've been involved in recently, to take that very temperature check. I think it may have been Alison or Gillian, I can't remember who had used the term, but to take that very check with our staff to see where they are, how they're getting on, and how we move forward in supporting them in carrying out their duties as goalposts continue to move almost still by the day, bearing in mind the First Minister's statement yesterday about rising COVID cases. So I think we've perhaps got an opportunity to engage with the workforce in that regard and support them and move them forward too. Thank you.
I think that's a useful suggestion, Chris. Jill, I saw your hand went up there.
Thanks, Chair. Just absolutely a really good point, Chris. And I think during the first probably year of the pandemic, we did go out to kind of wordles and how staff were actually feeling on the ground, and looked at what actions that we could do to support that. And I think some of that did come through, which obviously has staff side representation from yourself and from NHS staff. We're in a position in the NHS at the moment, we run iMatter again. We need to be really careful that we're not sending out lots of different surveys at lots of different, because we'll end up not getting a good response rate, and that then doesn't give us the rich information that we could get from that. So I think good point. I think it is something that we could consider, and we need to look at the timing of that to make sure that we get as good a response as possible.
Great, thanks, Jill. I know that Peter Drury and Councillor Speed have had their hands up for a while, so I'm going to bring Peter in first.
Thank you, Chair. Quick question on vaccinations. Obviously, the programme has gone extremely well as anywhere, I think. But my question concerns the 6 or 7% who have not been vaccinated. I assume we know who they are, and I assume they're reachable if they're within Angus. But two questions. Are they in Angus, or might they have left as EU nationals or as students, for example? And do we know why they are not vaccinated?
Okay, thanks, Peter. I don't know who wants to take that one.
Yeah, Gail's got her hand up. I'll let Gail come in and I can add something to that.
We don't know exactly who they are, but we can make some best guesstimates there, Peter, about where they are. And I know that there is a significant amount of work across Tayside trying to reach out to people. You know, I think the phrase at the moment is hard to reach but easy to ignore. So you're absolutely right that we need to target that group and find out a bit more about that. But that's very much in the hands of my public health colleagues.
Okay, thanks.
Thank you.
Councillor.
Thanks, Emma Jane. Yeah, firstly, just my extended thanks to the health and social care workforce across Angus. You know, it's just the ongoing work, hard work, dedication and commitment has been phenomenal. Councillor Bell obviously touched on kind of staff's health and well-being and, you know, the impact that it's having. And I think it was Mrs. Galloway that kind of gave that kind of burning amber kind of marker in terms of the workforce. And I think for me that just kind of draws concern to our carers who are unpaid carers who we know are under considerable pressure, and I'm sure they must be, you know, hitting an amber red, you know, if they haven't already. You know, I'm pretty sure that you know, there's risks that they could be. I'm concerned about obviously the delayed discharge, the impact on accommodation and people's homes, or accommodation not being kind of fully equipped to be able to accommodate them at home, and out of area displacement of care, as well as just the ongoing pressures on our care providers. And I just wanted to kind of just seek a bit of clarity with regards to the 13,200 personal care hours. Of course, that doesn't include kind of additional social activity. But is that 13,200 the assessed number of hours that is being delivered, or is that the number of hours that should be being delivered? You know, what I'm looking for is, you know, where is the kind of shortfall of unmet needs? How many hours are not being met?
George?
Okay, so the 13,400 hours a week is the number of planned care at home hours. So there'll always be a wee bit of slippage on that, in that some people cancel some sessions, or, you know, for whatever reason they won't come off. Somebody may go to hospital, for example, so they won't need the care hours, they'll be in hospital. There's always a wee bit of a difference between planned and delivered, but that's planned hours. And that is only personal care provision. It's all services, the 13,400. And you probably know, Lois, that it's recorded in a different way for care and support. It's confusingly called personal care and personal care and support. I just wish they just call it support. But so we have those figures as well. We've got data on that, but I was only quoting the personal care hours. What was your second question? Sorry, Lois, I've forgotten.
Yeah, thanks, George. So it was around the, you know, what's been assessed and planned hours of delivery and what's actually being delivered. So, and I guess I'm asking that across both the personal care and the kind of social care aspect as well. So how many hours of care is not being delivered?
Yeah, we haven't had problems with lack of delivery up to now. We've been able to expand provision as need has required it, so we're not failing to deliver. And now, you know, we've been speculating, has that plateaued now? Are we going to go into that territory next? If people are still having trouble with recruitment, are we going to get into that? And I think I've described it here before as we've managed just to keep our noses ahead of the demand, but we haven't had problems with delivery or not being able to meet needs so far. I mean, that's a rapid expansion that we've done in 18 months, unheard of before. So I've always said, yeah, we've kept our noses ahead of that. We've been able to deliver. Looking ahead, will that become more problematic? I don't know. If we settle around 13,400, I think we'll be okay. If people come back from holidays and we've got some issues along long-term sickness and so on. We had a glitch probably about a month ago with lots of people after the Wembley trip, it seems, isolating, lots of staff off, isolating, and, you know, that's began to settle down as well. But we monitor this. The resource allocation meetings take place twice a week. It's really closely monitored. We've got somebody who's full-time on that job, Pauline Reid, as you probably know. So we get really good data and we're really able to monitor it. So we're alert to it, Lois. I personally don't think we're going to get overwhelmed, but you never know. I don't see there being a big surge all of a sudden, unless something happened and we got a lot more folk off sick, for example. That would be a problem.
Okay, yeah.
I'm not feeling too worried about it yet.
Okay, thanks, George.
Okay, and do we have any other further questions? Jill, your hand gone up.
Thanks, Chair. I think Ivan had his hand up as well. Okay. I think, Councillor Speed, just to pick up on your question around the delayed discharges, some of the accommodation needs aren't quick, significant changes and alterations that need to be made. And I think whilst we did make out of area placement, I think that would obviously be done taking the individual and their family circumstances into account as well, as much as possible, to make sure that we are providing the needs from a clinical perspective, as well as obviously a social care perspective. But certainly the accommodations, they're not all quick fixes or insignificant pieces of work. If I could just pass my thanks on to Sally Wilson, who done a lot of work around pulling this report together. Before my thanks to Sally for pulling this report together, because it does take a lot of work. So thank you, Sally.
Okay, thanks. And Ivan?
Yeah, just a couple of quick points about vaccinations. I don't know if the board are aware, there were 2 organisations that had care homes in Angus that have mandated all of their staff to have the vaccine, and they've been given a date of when they have to have that. And as far as I understand, the refuseniks are beginning to take that vaccination now. So they're national UK-wide organisations that have obviously moved up their policies from England to Scotland. So that's going on at the moment. Staffing support, there is work ongoing around care home staff support that's being looked into, and that will be moved on to care at home and daycare staff once we've got that set up. That's being looked at. And just to say on the staffing thing, it's not just care homes and care at home. We're also hearing that the agencies have got no staff to support any vacancies that the care homes have, at least this week and next week.
Okay, thanks for that, Ivan. Okay, do we have any further questions on this paper? No. So if we would just move to the recommendations, which are around noting the actions that have been advanced in response of commending staff and key partners for their continued and sustained effort and commitment to provide care. Are we happy with those recommendations? Yep. And I think it's understandable and I think welcome that we've had a very useful focus on staff well-being as well as we've been discussing this paper. So thanks to everybody for all of the information that you've provided in that area. Okay, we'll move on now to agenda item number 7, which is the strategic planning progress update. And George, I think this is you.
It is indeed. Thank you, Chair. Okay, so people will be familiar with this report. It's the one I'm duty bound to bring to every second IGB, and it really considers all of our change programmes. This report, or the content of it, has been considered at the strategic planning group as well. One thing that's happened since my last report is that we have merged the Improvement and Change Programme Board projects with the Angus Care Model projects. We said we would bring those together, and they're all now one set of activity under the title of the Angus Care Model. The first section, or section 2 of the report, just describes the approach that we take to those change programmes and why we do it that way. And the second section there is about COVID and the impact of COVID on the change programmes, which really has been to delay progress in them. We're coming out of that now, getting back to some normal business. But as I said earlier, there is a bit of work still going on, particularly around care homes and care at home and how we manage risk there, and that is still taking up a bit of people's time. Over the page to section 3.1, I was, I think, asked at the previous meeting to put a bit more in about the operations of the strategic planning group. They were suspended or operating pretty minimally at the height of the pandemic, but we've now got good momentum going around the strategic planning group. I chair that group just for information, and we worked hard at the last meeting to, I think, reconnect the work we were doing with the strategic plan, the current one and the one to come for the future period. And I've outlined some of the things we were working on in there. There's particularly a section about the strategic commissioning and plan and how we're going to approach that work. The National Care Service and how that develops might cut across some of our plans or influence them in due course. You would expect that. But of particular note, I think, and probably the one thing that we haven't managed to do effectively within the existing strategic plan is our work on prevention and early intervention. So we're having a big focus on that and trying to pick that up. I was also asked to include workforce planning elements in this report. I haven't done that today because we have a separate workforce report later on in the agenda, so I didn't think there's much point in duplicating that. A mention of procurement here. Procurement is millions of pounds worth of business to the services. You know, we've spoken about the 13,400 hours of personal care, 1,000 hours of personal care per week extended for a whole year is about £1 million. So it's a lot of money we have involved in procurement, and we're looking to develop a more strategic approach to procurement. The physical disability and learning disability improvement plans are separate reports, so I'm going to leave that until we come to those in due course. The care home review, you can see there are quite a number of, quite a range of activities within the care home review. Two of those are currently involving follow-up to prior information notices, looking at interest in them, and that's the mental health unit and the psychiatry of old age development. I'll not say too much about those. I'm conscious that procurement confidentiality rules will apply, so I haven't put a lot of detail in there. It wouldn't be appropriate for me to say who the interested parties are. The permission we had from the Igb before to look at transferring resource from care homes to care at home, given the change in demand patterns and the reduction of 40 beds across the care home market. We're taking that forward. We said we'd look at options appraisal. We're not quite there yet, but we are working up the options for change. I'll not go through the whole section, there's a lot of detail in there. I would like, however, to say a bit about the daycare review and just take a few minutes to do that. As everybody knows, our drive is to keep people at home in the community for as long as it's safely possible to do. That's what the research tells us, and it's what people want. So daycare is really quite an essential part of our range of tools to manage to do that. Popular service. We're just getting it back to some kind of normality just now. It had periods during COVID when it was suspended, and we're still struggling a little bit to do that within the constraints that we have around social distancing, mask wearing, transport, etc., etc. So that's just constant work for the care at home group. I'm going to start with D on there, which is about engaging providers in a shared strategic approach to the future provision of daycare. My ambition is to have the same relationship with daycare providers that we developed in the Help to Live at Home and the Fair Cost of Care with care at home providers, that we co-produce the future of daycare. I wrote out to the daycare providers on Friday, I think it was, just to give folk a heads up about what was coming in this report so that people were cited on it, and our genuine desire to engage with the providers to create something together for the future. There's a few factors involved. Geographical considerations is the first one. So we've got 4 daycare centres in the north, 1 in the south. That's at Kinloch. I think that's a bit out of balance. Kinloch is at risk of not being able to meet all the demand in the south, and we don't have any provision in Arbroath, our biggest town, which is just not quite right, I think. So we need to look at that. And the second point in there is about a tiered approach. So day centres, broadly speaking, meet 2 types of demand: a kind of more early intervention, generalised support provision, and a higher tariff of intervention, which probably avoids people being received into care. I'm talking here primarily about older people services ones, by the way, not the learning disability centres. So we want to look at developing a tiered approach so that we have the right provision in the right places across the county of the right type. And finally, a financial model that can meet the need, but which is affordable in terms of cost to the organisation and what people can actually afford to pay. And I think we have to have a look at that, the whole finance model and the charging model. So we're looking at that as well. So just a major area of development for us. The next thing at 3.6 is about supported housing. I'm going to try and explain what's happened there. It's a wee bit tricky. So pre-pandemic, so I should say first of all, supported housing is not sheltered housing. It is a tariff higher than that in terms of intervention. Most of the people have got higher level needs that are in supported housing, and this applies to St Drostan's in Brechin and Provost Johnson Road in Montrose. So prior to the pandemic, what we had hoped to do, what we were wanting to do, was to provide personal care services in-house in those settings. That's tricky to do under SDS, but we did find a way of doing that. What happened during the pandemic, so there was about 18 months of this, was that the beds began to be, or the tenancies began to be taken much more by people with learning disabilities. And that group of people came in with existing care packages and didn't want to change those because naturally they had relationships with the providers of those packages. And as the numbers changed in balance between folk with learning disabilities and older people, that meant that we were no longer able to follow up our plan of delivering that service in-house. So we've just not been able to do that because the numbers have changed significantly. So what we're going to have to do is gradually phase across the services to a concierge-only model, and as we do in Kinloch Care Centre already, we'll do that over time, and the people will gradually, who need personal care, will bring that in this, older people in the same way that people with learning disability do. And this will affect about 10 staff, and that work's progressing under the Managing Workforce Change process, and it has been discussed at the Staff Partnership Forum. I'll pick up also from that section the Adult Protection Committee report in June, where the annual stats were submitted. There were very major increases in adult protection work over the last year. You can see some of the figures there, really striking. 79% increase in adult protection referrals, adult protection investigations resulting from referrals increasing by 169%, number of case conferences up by 90%, etc. So that is resulting in very large amounts of increased work for care management teams and the other professionals involved as well, obviously. There are a couple that are a bit in their infancy, so the homelessness review and the urgent care review, pretty much early days for those. And I should point out the MFE inpatient review, that work's nearing completion, and a report will come about that to future IGB meetings, or to a future IGB meeting. Just to highlight one thing from the financial implications, Sandy's already mentioned it, I think. The projects running behind their original schedules due to COVID and not delivering on time, that does present a risk to some of our strategic financial planning. So some of those are behind, and there's a risk to the savings there. I've picked up in the risk section potential disruption caused to the programmes by a further COVID-19 outbreak. That's always a possibility. That people get pulled back into doing COVID work all the time. Capacity amongst staff and managers to prioritise the work. It doesn't take a lot to tip that over, and it becomes more difficult to do. So, for example, if you had a shortage of staff or something like an inspection that pulls in a lot of staff time, it can get in the way. I've said already about the risk to plan savings, and corporate services lacking capacity to support the programmes. Nearly all of the programmes of change have got procurement or human resources elements to them, and we need people from the parent bodies to help with that. So if that's affected in any way, it makes it more difficult for us to deliver those on time. I think that's probably about it. I should mention about the change programme objectives. Whether they have financial elements to them is quite individualised in the extent of those financial objectives, but they're all meant to be about providing better services to the public, and I should stress that's the starting point for all of them. Okay, will I go to say something about the recommendations, Chair? Is that okay? I've just got one thing I wanted to say. Yeah, the second one there, to be honest, originally I was a bit uneasy about this. So the Scottish Government said we could extend the the deadline for the completion of the new strategic commissioning plan by year to 31st March 2023. I was uneasy about it because I was worried about us getting caught in a lull between the old one and the new one, and therefore not making good progress. However, I had a long conversation with Vivian Davison about it, and also we discussed it at the strategic planning group, and I was persuaded that it was something we did need to do, really because of the work that is planned and pretty extensive requirements by way of consultation on the new strategic plan. We probably will need all our time, and we're behind in the race, if you like, because of COVID, obviously. So I am persuaded that that is the right recommendation to make. Okay, thanks, Chair.
Thanks very much for that, George. There's a lot of information in the report, and I think what struck me was really that despite the challenges, there's an awful lot of good work has taken place, and it's very good to see it highlighted in the report. Questions, Councillor Bell?
Thank you, Emma Jane, and I absolutely concur with your remarks there. There's a lot in that report. Thanks, George. I just wanted to pick up on the daycare review, and I guess a bit of comfort that would include looking at our dementia pathway around all of that, and the post-diagnosis support, I guess, sort of wrapped in with the Kiddie Connections development worker, that'll all tie up, just to give me that bit of comfort. I'm sure it will.
Yeah, it will, Julie. We'll do that. We're very conscious of the needs of folk with dementia and the way that those needs change during the lifetime of your attendance at daycare, if you like. So if you're somebody who starts off in that lower needs group and have Alzheimer's 3 years later, you're going to be in the higher needs group, and we recognise that movement. So yes, we'll be involving lots of stakeholders in that discussion.
Okay, Alison?
I just wanted to highlight that while we're looking at meeting the needs of this year's strategic plan, part of the risk about meeting our commitments under the strategic plan is looking at a focus on prevention. And I'm really quite keen that we highlight the need to look at preventing people becoming ill or anticipating frailty and acting at that part of the pathway. And we've had a lot of conversations earlier on about how we manage risk and being a bit brave. And I think as part of the strategic planning risk in the future, we'll be looking at how we move to the earlier intervention and some of the work on the physical disability and learning disability. I know you're saying it's about quality and not just about the finance, but the finance part of providing care is important, but also the escalating demand that we've got just as the population ages. If we're going to manage that, we need to act earlier, and that's not just about preventing people getting ill. It's about managing long-term conditions effectively, but it's also providing carers with support earlier in people's journeys, anticipating care, making sure care is coordinated so that people can manage independently for as long as possible or in their communities well supported. So I'm quite keen that as we move forward, that we think around the prevention aspect of the strategic planning risk as well.
Thanks for that, Alison. Councillor Miles?
Yes, thank you, George. My question's on point 3.6, the supported housing. I know quite a number in supported housing complexes that have extreme concern over what's happening. Has there been dialogue with the residents there to explain what's required? And at one point you say they usually have care packages. Disabled people with learning physical disability usually have well-established care packages. If they don't have that, what's the alternatives? And has that discussion been had with all the residents so that they know they're not losing out? Because that's the feeling they have at the moment.
Okay, I think Gillian Richmond has those discussions underway, Bob, and there's a briefing available about where that's got to. About care packages, SDS assessments are not constrained by setting. The statutory duty is for us to undertake an assessment of need and provide services commensurate with that need, or commission them from elsewhere. So that doesn't matter if somebody's in their own home, in a supported housing environment or in sheltered housing. If it comes to our attention that there is an indication that somebody needs an assessment, we will do an assessment. Now, sometimes that might result in fairly low-key interventions by way of support. So, you know, Care About Angus interventions, for example, would be one. But sometimes that will result in higher tariff interventions, which we are empowered to deliver under SDS. So it doesn't matter which setting you're in. If folk need those services, they will get those services. But what we do find, what we found before, was that there's far less demand for those higher tariff services in sheltered housing. I think probably only about a third of people, when I last looked at that, and it's a while back, it could well have changed, required the higher tariff SDS services. That will be much higher in supported housing. What I'm not going to say is every single person in there has one, because no doubt there will be somebody who doesn't require that, and there'll be a reason for that. But for as a generalisation, far more people in supported housing, because it's a higher tariff service, will have personal care provision.
Okay, and Councillor Speed.
Yeah, thanks, Jane. Thanks, George, for that detailed report. Just going back to the care home review, I appreciate the reasons why there isn't any more detail with regards to Seaton Grove and the prior information notice, but I just wanted to ask if there will be a report coming to the next IGB with regards to that. And also just on 3.6 and the supported housing, Councillor Miles covered a couple of points I was going to make with regards to service user involvement and consultation with them, and you've answered that. But I was also just seeking a little bit of clarity with regards to the kind of the age of tenants that go into those supported housing complexes, and whether, you know, people with a learning or physical disability have got choice with regards to that move. I would imagine that some might want to stay together, but some might not, because, you know, we were shifting away from grouped living, and it does point out with regards to the fact that 10 care home support staff jobs will be affected, but as it's got there, I would imagine the workforce change programme is picking that up, because we'd be looking to keep them within health and social care, I would be hoping. So yeah, a couple of questions in there, I think. Hopefully I put that across okay.
Yes, you did indeed. Sorry, I was slightly distracted. My dog chose that moment to decide to climb up onto my lap to be petted. Sorry about that. Don't know if she made a quiet appearance on the screen there. So, Seaton, yeah, I think probably what we should do is bring a report back with a bit more detail around the whole residential care review and where we've got to that next time, Lois, rather than kind of single out the Seaton Grove development. As you can see, there's quite a number of different things in there. So if that would be the preference of the IGB, I would be happier to do that and bring a general report around, including Seaton Grove, around all of those developments. The age of supported housing people, I don't have any stats on that, but we took this developed, I suppose, through practice rather than an overt policy decision. So we've never said that supported housing was only available to older people or to particular age groups of people. Like yourself, Lois, I do not like the idea of kind of gated communities or communities that are all about a particular age group or folk with particular groups of needs. And we began a few years ago now to make those tenancies available to folk with learning disabilities. Obviously, people whose needs allow them to be relatively self-sufficient in the community with support. So we've got young and old in there, I guess it would be fair to say, and we don't have an age constraint on that, and we haven't had any problems with the mixture. It seems to have gone pretty well. Now, I'm not saying that every single client group would work in that way. You know, I think probably folk with substance misuse issues bring another set of challenges which might not be a great fit within older people's service. grouping, if you know what I mean. But I think this has worked pretty well, and we know we're not getting kickback from either group really, or their representatives about it. So I like it as a model. I think it's good, but you can see from this report it's caused us particular issues around the delivery of personal care.
Yeah. And Emma-Jane, is it just, if I just seek another point for clarification with regards to, is it the Health and Social Care Partnership as opposed to housing that are taking it? Is it a joint approach? Is it?
Joint approach, yes, yeah.
Yeah. Okay, thank you.
Okay, thanks. Okay, so if that looks like all the questions, so if we move to the recommendations, and I think what we just probably added one in there in terms of bringing a report back to the IJB on the care home review as well, that we were speaking about in that last point. And I think just thinking about the overall review of the strategic planning, I think it mentions in the report that December is whenever you're going to be starting sort of engagement work. And I think it's just, I guess, some assurance in terms of our earlier session on risk as well, and Alison's point about focusing perhaps on early intervention and prevention, ensuring that we're taking that approach whenever you're looking at reviewing these strategic plans as well, and considering, I think it mentions in their blue sky engagement opportunities, which I was quite pleased to see, taking all of that into account whenever you're moving into the next review period, I think would be very welcome. Okay, are we happy with the recommendations for that report then? Yep. Okay, so we're moving on to agenda item number 8 now, which is the Angus mental health and wellbeing update. And I think I'm handing over to Jill for this one.
Yeah, thank you, Chair. Again, we were asked to bring an update around the Angus mental health and wellbeing provision across Angus. So I have obviously included quite a detailed report, so I won't go through it line by line, Chair. I'd just like to highlight a few things. I think just to acknowledge that there are a number of areas of work that have progressed within Angus mental health to review and update, redesign our services in line with Living Life Well, but crucially the importance of the key stakeholders being involved, including service users and carers. And we have got a really good Angus mental health and wellbeing network who actively support this development. In terms of workforce, you'll see that we have increased the workforce quite significantly in quite a varied roles across. The development officer who is coming into post in the next few weeks will be critical to us in terms of supporting the development of our Angus implementation plan. Again, all 3 partnerships are looking to recruit a GP lead for mental health. Really positive step forward and supported by the primary care community. So they will be going out to advert very soon. And just to pick up on one additional post there is around the pharmacist and the support that the pharmacist has actually given the community mental health team to support the prescribing and a number of other clinical situations within mental health. That's actually been a really positive move forward and has added quite a bit of value to the team, and we are looking at how we can expand that and share some of the learning from the mental health side of things, bringing a pharmacist in across substance use as well. The implementation plan specific to Angus, we are due to this implementation plan in October to IJB, and just to confirm we are on track for bringing that back. We have included quite a significant input around the service development, and I will go through them because they're actually very positive, Chair. The 7-day mental health service, as per one of the reports at the start of the year, we commenced this in April, and we are still on track to roll that out across Angus at the end of September. We're in the process of gathering some data and doing some evaluation of that service as well. The links, enhanced community support, which commenced in Montrose, has also been positively evaluated. And I think that's moved on quite a bit because it links back to what Alison was saying around linking mental health with physical health as well, and learning from the work and the links around the mental health ECS, along with the work that George led around the Money Faith integrated care, and how we can combine that and take forward and progress to spread across all of the locality areas. The other thing that's really positive in that section is around the comorbidity pathway. Is something that's been held up and spoke about nationally, as has the ECS project. So some really positive pieces of work there within the team. Just from an Action 15 perspective, all I would like to highlight to the committee or the board is in relation to staff that we have employed. We've actually exceeded our target for recruitment in 15, and we are on track to employ 20.7 full-time equivalent against the target of 17.2. So really good, and I think it just demonstrates the commitment to support mental health and wellbeing within Angus. The Lesson Learned Change Action Plan, I've just put a brief update in there in terms of the performance across, and as board members will be aware, we have had the progress report from David Strang with the key findings included in this report. There were 5 actions which are listed in the report, and just in terms of recommendation 5, that was the joint working between chief officers, chief execs and other exec partners, and that work is ongoing. Finance, I'll just pass over to Sandy once I've finished, if that's okay, and he can add anything around finance, because I know that one of the recommendations is awaiting the financial framework to support the strategy. Just moving on to the risk section, obviously Councillor Speed has raised Seaton Grove, and we'll bring that further paper back. But just to note that since this paper was submitted, there has been further discussion around that and the need to review the demand for this, given that the original paper was approved, I think, back in June 2000, and part of the paper that comes back around residential care. And again, just to note, from an inpatient perspective, there hasn't been any progress in terms of finalising the work that the inpatient services have been doing around the location of inpatient services. So whilst that is continuing, we haven't had an outcome of that options appraisal at the moment. And I'll just leave it there, Chair, if that's okay, and take questions. But if Sandy's wanting to add anything from a finance perspective.
Thanks, Jill. Honestly, I'm just looking at what I've said in that report, and I'm not sure there's that much more I can helpfully add to what we've said there. So I'll just take any questions on that.
That's great. Thanks very much for this report. I think mental health has been a standing agenda item at our IGB meetings for quite some time, and will continue to be. So really just highlighting how important this area is, and an area of focus for the IGB. And I think I'm glad, Jill, that you've highlighted some of the very positive work that's taken place, and the amount of progress that's been made in mental health provision across Angus. Thinking in terms of the appointment of a development officer and a GP mental health lead as well. And I'm sure we'll all very much look forward to receiving the implementation plan, which will be coming back to the IGB in October. That, of course, being one of the recommendations from Dr. Strang's recent update, and certainly at a local level anyway, that we will have that implementation plan. I think in terms of creation of the Living Life Well strategy, there was obviously a lot of engagement work took place to form that strategy, but we're quite some time further on now, and the effects of the pandemic on people's mental health are continuing to be revealed, I guess. So in terms of how we learn about what people need and how they like to access service, or where is best for them to access service, I suppose it would be a plea in terms of considering new ways of engaging with people, new ways of reaching people, maybe things that we haven't tried before. I think that would be a very important focus going forward in terms of as we continue to develop mental health services. And I think, and just on the final point on finance, so I'm assuming with the implementation plan, we will have a finance plan alongside that. Given that the overall strategic financial plan hasn't been finalised yet, how far can we actually go down the line in terms of developing our own financial plan that will accompany our specific implementation plan? So a few comments there and a question as well. Thanks.
Thanks.
Okay.
Oh, Sandy, are you going first?
Yeah, sorry, Chair. I'll go first in terms of that last question. How far can we go in developing our own implementation plan when we don't have an overall strategic financial plan? I think the answer to that is, we can do quite a lot. When we're putting plans together, they are two things. They are an overall plan, and there's a series of individual things happening in overall plans. And if we think about what we do across IGB, we will agree individual parts of an overall plan. Now, for us, that might be something about one service, something about another service. But within mental health, it'll be one part of one piece of change, one development, another bit of change. So we absolutely can look at individual things that all kind of stack up and have a good rationale for themselves, make sense, help deliver the strategic plan for mental health, and are consistent with overall financial planning parameters. We can do that. We're not completely dependent on having an overall plan. However, ultimately, we do need an overall plan, and the components help contribute to the overall plan, as does a lot of the background information. So I don't believe not having an overall plan will hold us up doing specific things. It might make making one or two judgments about bigger things a bit harder, but for a lot of the things that we're capturing in this paper, it won't hold them up, because we have clear smaller plans that are there's a complete rationale behind them, completely stack up. So there's a kind of for most things it won't hold us up position, but one or two other things it might hold us up a wee bit.
Thanks for that. That's reassuring. Jill?
Yeah, thanks. So Sandy's pretty much summarised that fantastically well, so I'll not add anything to that. In relation to engagement, Chair, I think it is worth noting that we have got a very positive and engaged Angus Mental Health and Wellbeing Network, and the people that are involved in that have backgrounds and is heavily input with stakeholders, carers, service users. They are very active and they do work very well with us to inform what it is that we need for Angus and how we're going to take that forward. So that's from an Angus perspective, and I am assured, and I think that there's always going to be learning in terms of how we consult and engage with the population or communities, and in particular we've learnt a lot over COVID around how to do that in a very different way. So absolutely accept your comments around that, and I think there will always be things that we can do differently, and in particular around that the impact of COVID on mental health and the age distribution for that. So some of the younger people who are having mental health implications as a result of COVID, how we interact with them will be very different compared to how we would interact with an elderly population, for example. So there will be very different things that we can do targeted to the needs of the age group as well.
That's great. Thanks very much, Jill. Okay, Councillor Bell.
Thank you, Emma Jane, and Gillian, thank you for this. It's such an important focus for us, particularly in light of COVID, but it was before anyway. I've got a few points, a couple of questions in there, and I wanted to kick off, if that's okay, by just reflecting that in Dr. Strang's report in July, he actually stated that all 3 IGBs had approved the draft mental health strategy for Tayside, which is incorrect. The Angus IGB noted its development and progress, and that's partly because of the lack of the financial framework. And I think it would be important for our minutes of today to reflect that, if that's okay. I did feed that back to Margot Williamson at the time. 7-day service start to get rolled out. That feels like a long time in gestation, and it's a tangible result for us, which is great. I have a question about the comment on page 65 around the Mulberry unit and the options appraisal that NHS Tayside is looking at that. Is that something that will come to all 3 IJBs as well? And I don't know if there's anything more you can say on that. The risk register matrix that's there as well only has colours on my version. It doesn't have any scores on the matrix, and I just wondered if that was intended or not. And I guess picking up on the points that both Emma Jane and Sandy have made about the finance, I guess if we get to a place where there's an issue over that, then we've got a process in terms of the use of directions to resolve that. Perhaps I would hope it would be resolved before that, but as we've covered before, that lack of the financial framework does give me a bit of anxiety. And that then leads into my final question, which is a slight diversion, but the former Mulberry unit, has NHS Tayside released funds to do the work that was required there to allow it to be used for older people's care? So that's me. Thank you very much. Sorry it was so long.
Thank you, Councillor Bell. So in terms of the specific question around Mulberry, my understanding is that is still being discussed through the Mental Health Strategic Leadership group, and Gail would be able to advise in terms of if that will have to come back to the IJBs for approval. I would assume that it would, but Gail will be able to advise on that. In terms of the risk register, we should have had scores on that, Julie. Apologies for that, but I think in light of this morning's session, our approach to them in the future reports will be very different. So lots of learning from this morning. Gail?
Yes, the intention is to come back to the IGBs, but I will certainly be asking for that. Julie, that's quite correct that you've raised that.
And in terms of the work, Julie, my understanding is that there hasn't been specific work undertaken in Mulberry to make it fit for purpose for older people, either because they're still awaiting the outcome of the inpatient review for mental health.
Okay, Peter.
Thank you, Chair. And that Councillor Bell, just to thank Jill for this update. It just shows that there's some really positive steps being taken to address a really concerning and a growing concern area. A couple of points, probably a couple of questions. You make reference to social prescribers. I suppose I just want to commend the work of the social prescribers, not just through COVID, but as we come out. I suppose I have a little bit of a concern over their workload and their capacity, just like that of our medical professionals. And I just wonder if they are coping well, and if they have enough opportunities within the community to refer to, or if that's a growing concern. With children and young people, I'm really pleased to see the mental health and wellbeing peer workers, but again, going back to social prescribers, I just wonder if there's any thought around growing the social prescribing provision to include children and young people to try and reduce any form of waiting list that's currently building up, if that was deemed to be an appropriate route of support for them. And I suppose my final point would be around the implementation plan. I'm really reassured to read that the third sector and people with lived experiences are involved in the development of the plan, but I suppose I'm just asking if you feel that these stakeholder groups have been sufficiently represented in the formation of this plan.
I see Hayley has helpfully put her hand up, and I'm assuming that will be around the social prescribers. Hayley, and I know that you'll be able to comment on the implementation plan as well. So if I can pick up on that point first, Peter, and the network that we have are very active. So I absolutely do have assurances that they are sufficiently involved in the development, and in fact they're informing the development of some of the key areas of work. So I think that, and with any plan, it has to be an iterative document as well, so that we can continue to review, monitor progress in line with the changing landscape, changing environments as they go along. In terms of the social prescribers, Hayley, do you want to comment on that yourselves around that?
Yeah, thank you. Yeah, in terms of the social prescribers regarding, I suppose, first of all, capacity and workload, absolutely, Peter, you're right, they are very, very busy. But I think that the impact that they're making is absolutely fantastic. And I suppose in regards to how they're coping at the moment, they're doing all right, and they're absolutely supported through myself, and they've got a good team around them in regards to locality workers and other people. You mentioned about enough referral routes for the social prescribers, and I would say that has been a bit of an issue in recent times, but I think that is due to community groups and things starting to reopen up again. So a lot of things have been closed down, which then provides a kind of stumbling block for the social prescribers to move clients on to the next sort of steps, if that is the stage that they're at. So yeah, there has been that sort of limbo land a little bit, but that is improving. We're monitoring that. As I suppose what I'd like to say is in regards to social prescribing support, we at VA have been through a number of changes recently, but actually some of the positive changes is the fact that we've got we've done some recruitment around having a full locality working team, which obviously we're missing due to maternity leave and other things. So we do have locality workers now in each area again, which is fantastic. And they will be the ones that will provide that support to the local social prescriber, and actually they would be feeding in to let them know what's available in the local area. So hopefully what I'm looking to see in the next few months is that keeps on growing and opportunities continue to grow and flourish in each individual area. And if there are gaps, in locality workers would be the ones that would support volunteers or other members of the community to fill those gaps and encourage new things to be created. That's where we're at with the social prescribing model. Absolutely be open to extending that model. Obviously with that comes funding issues and other things. So yeah, always open to have a conversation around growing that, because absolutely it's beneficial and it works. But that's something that maybe we need to look at in a bit more detail.
Thank you, Hayley. Appreciate it.
Alison.
Thank you, Chair. I was one question around links with CAMS and children, and I can confirm that as a people, so the Angus Health Social Partnership doesn't have responsibility for children's services, but primary care does. And so through the clinical partnership group in Angus, where we're working with GPs, we have linked with the CAMS service across Tayside and adopted a successful model that worked in Dundee into one of our Angus clusters with a view to growing that. And that's where, rather than referring to CAMS itself, we refer to a CAMS liaison person, young person's worker that is working aligned with the practice, who's more familiar with local resources. And that avoids people going on to a waiting list where possible. Now, as a GP, I have to also tell you the other side of the coin, that there is long waiting lists and around waiting lists, particularly for people with perhaps suspected autism or ADHD. So it's not all good story in terms of how we're working with CAMS. We're doing our best and looking at the pathways. But certainly that model of care is rolled out at present in Carnoustie and Montefieth. A lot of interest across the clusters. We know it works and build on that. But yes, absolutely, our GPs in Angus are very keen that we work on alternatives to a CAMS waiting list for our children and our communities, and very willing to work with the third sector across the piece to support that.
That's very helpful information. Thanks very much, Alison. Okay, if we have no further questions, we'll just move on to the recommendations for this report, which are to note the progress and to request the implementation plan to be brought back to the Angus IGB in October, and to note the risks detailed in the report, and to note that the financial framework to support the Living Life Well strategy remains outstanding. So are we happy with those recommendations? Yep. Okay, thank you. So we'll move on to item 9, which is the oh, I've just passed it by, the physical disability priority improvements, and the next one is the learning disability priority improvements. So we've all had a chance to read through these documents. Thank you very much, George. You're going to speak to them today. So if you want to highlight some of the key points from the physical disability priority improvements first, thanks.
Will do. I've also got Linda Kennedy and Morgan Lowe waiting in the wings for any really detailed questions. So I appreciate they're quite big documents, folks. And I've just picked out half a dozen key points, but a wee bit of context first. Folk will appreciate that we have a disabilities service within the partnership, and physical disabilities is part of that, but it's only been there for about 3 years. We lifted physical disabilities, if you like, out of older people's services for, I think, what were good reasons, to give it better attention and improve the skill set and so on. And that has worked well, I would say, but the scale of the service has increased pretty rapidly. When we set it up, we were expecting about 120 cases in the service, and it's now up to 230. So something has happened, and I've got various theories that I won't go into just now, but the reasons for that, as will the managers. So that budget for that service has increased dramatically as well. It was 1.9 million, I think, 3 years ago, and it's now 3.6 million. So that's really reflecting the increased demand. I should say that, you know, this improvement plan is not the whole world of physical disability. It's quite important to stress that. And it covers the care management, personal care provision and care and support provision, adult protection, adults with incapacity, residential and daycare provision. It's not the whole world of physical disability, quite important to stress, but it has interfaces with all the other bits that are important. So key bits, I think, are to, you know, we're seeking to approve the finalised improvement plan and the action plan. We've put in there the funding for a dedicated post. I think on second thoughts that is probably too small an issue perhaps for the IGB to bother with. It's probably well within Gail's delegated function. So I mind to just remove that recommendation. I think it's something that we have the authority to deal with ourselves. The second point to highlight, I think, is the demographic pressures. As I've said, it's experiencing exceptional growth and demand, and we maybe underpowered it a bit when we set it up, looking back, maybe not anticipated precisely the kind of increase in demand. Day services, a review of the Glenloch Centre is required to determine the future requirements for day services and rehabilitation. Engagement, I would like the IGB to note the work that we've done to ensure accessible engagement materials were available in BSL and easy read formats, and a future pathway for document translation has been agreed, because I think we were tasked to improve that a bit before. Accommodation, we need to conduct a needs analysis of future residential care requirements and respite requirements for physical disability. Folk will be aware that at the moment, sometimes people are having to be accommodated in older people's care homes, for example, and we don't think that's good. If you're a 40-year-old person with a physical disability, it's not an ideal setting for you. And we need to review high and low cost care packages within personal care and support and care as well. So those are kind of the 6 big ticket items. I'll just quickly ask if Morgan or Linda want to add anything to those. Hello, Morgan and Linda.
Hello, George. Sorry, wasn't sure if we were permitted to unmute ourselves. No, thanks. That's covered everything. I think we just really wanted to highlight the efforts to improve our engagement materials and the new pathway that's been developed, so that we should be more secure in our engagement with groups who require particular types of communication in the future.
Thank you, Linda.
Okay, thanks very much, George, and to Morgan and Linda as well. Welcome today. So do we have questions? Councillor Bell.
Thank you, Chair. I actually had 2 points, and as you were speaking there, one of them went flying out of my head. So I'm going to try and scrabble that back. The second one was a very minor pedantic point, and I just wondered if we could move away from the high cost and low cost terminology. I mean, people receive the care that they need, and I am very uncomfortable about putting that cost label against it. Oh, and the other point was, I hear what you said about the delegated powers for the cost of that post, George, but it's good for us to see that investment is being made. So we might not need to see or give permission for it, if you like, or approval, but it's good to see it in a paper somewhere that it's captured, because it's an important service, and I think I'd certainly like to see those developments in the paperwork. So thanks for that.
Yeah, I think Julie, we know that we can't really achieve these big change programs without having dedicated planning time in there working alongside the operational managers. Yeah, I know what you mean about the high cost and low cost. It's a bit related to approval levels. Folk might remember we looked at those approval levels, authorisations for the spends basically, and beyond a certain level they come to me, and beyond a certain level after that they go into our high cost care packages panel, approval panel. So it's really to do with the approvals level, but we could probably come up with a better set of expressions, I think.
Okay, Councillor Speed.
Thanks, Emma-Jane. Thanks, George. Yeah, it was to do with the engagement. I do feel that there's kind of lack of service user and carer feedback being kind of highlighted or written within the report, which would have been really helpful. I know that there are a few quotes there, but it would have been good to just have a little bit more information with regards to stats and some of the feedback. I know that there was some in the last report that was brought, but it would have been good to see just how much more engagement had taken place. I certainly know of many service users and carers who were unaware of the consultations that were running. So yeah, I'm not entirely satisfied that enough people have been engaged with. However, there obviously is good information there with regards to what feedback has been given. How did people know that paper copies were available? I'd quite like to know that, because if the consultation and the information has only been publicised online, and people we know are often digitally excluded, so how would they find out where paper copies were? Moving on, I'm obviously concerned in terms of the increase in demand and the lack of provider capacity, or the potential for there to be real stretches there, as well as the kind of skills and knowledge and expertise, especially with regards to complex care needs, and what can be done to increase that capacity and that knowledge and that understanding across the workforce. It is a little bit disappointing to see that there is a lack of data around health inequalities, and it would be helpful to hear a little bit more as to how this information is going to be gathered. Also a bit concerned about the lack of no respite provision, which, clearly the report is highlighting that's work's going to be undertaken to look into what can be done to address that unmet need. But it does flag up concerns around the ongoing demand on paid carers and emergency care plans, and if there is no kind of respite provision, then what would happen if people reach crisis, especially if there was people reaching that crisis all at once. And with regards to the kind of accommodation, adaptations and respite concerns, the timescales within the report for addressing this is 2024. And I just have a bit of concern in that that's too far away, and the impact that that might have on kind of service users and carers' quality of life within that time.
Okay, Lois, that's quite a lot.
It's a bit of it, yeah.
I'll take one of them and then I'll pass over the more detailed stuff to Morgan and Linda. The issue about provider availability, we are coming up to, or in fact it might even have started now, a review of our framework under the fair cost of care. So when we developed that, I think we're in its 4th year, that was the first time we'd done that with specialist organisations for, you know, mental health client groups and learning disability and physical disability and so on. So I think we've learned a bit from that over that time, and that will feed into the next version of the framework. And of course, things change over that length of time. So maybe the best providers, you know, 3-4 years ago are not now the best providers, and other people have emerged as potential strong providers. So that bit of work is in hand, but that is how that will be addressed, and looking at the new providers framework. And of course, we're not confined to only bringing new people on the framework at those intervals. We can bring people on as when we think that's proper to do. So we'll keep working on that all the time, really. But the other ones I'll ask Linda and Morgan to address. So the paper copies, health inequalities and timescales, I think, were the 3 things. Yeah.
Thanks, George.
Linda?
Hi, I can answer in terms of the engagement and the paper copies. So we did send out letters directly to service users and families, which did indicate that they could request a paper copy. We also went to the likes of the Carer Centre, Angus Independent Advocacy, LIGS, and we also talked to service users and families directly through day services, so through the resource centres and through Glenlock as well. So we also advertised on Facebook, on social media, as well as the partnership website. And obviously we had our main engagement in February. We then paused that, and we then came back with more accessible materials in June, and we re-advertised with a lot of those key agencies to make sure that people were aware, if they had not had a chance to complete the survey, that they could go ahead and do that.
Okay.
Okay. And the next question, I think, was around health inequalities. So yes, that's a piece of work that we've identified that we need further information about. So that's the first step in our action plan. And similarly with the respite, at the moment people will receive respite, but it's what's been identified from I don't think we needed our families to be telling us this. I think our care managers and other stakeholders have been telling us this too, but it's not in the location that they would prefer, and we think we can do better there. So I think the first thing is to map need, because that's very different than the situation that we have for people with learning disability. We seem to know more about that population than we do about the people with physical disability, simply because physical disability can happen as a result of a car accident or a sudden incident. So we do need to do some mapping as to what the demand in terms of respite and permanent residential type care would be for people with physical disabilities. I think, does that cover all the questions, Lois?
Yeah, I think so. But I did have a concern with regards to the timescales and.
Yes,
yeah,
housing timescales. That's right. I suppose of course that is a long time scale for individual people, but we're not really looking at. We're looking at both ends. We're looking at a much longer term planning, linking in with the housing needs assessment analysis, and really looking at 20 years hence. So we're trying to do both things, look at our accommodation database for the current individuals that we're aware of, but also planning for, you know, much further into the future.
Okay, thanks, Linda. Thanks.
Okay, Peter Berg.
Yeah, thanks, Emma Jane, and thanks, George and Linda and Morgan. I've got three things. I wrote them all down, Julie. The first was, is there any reasons on 6.3 why we can't have a commitment to National Health and Wellbeing outcome number 6? I think that would be very strong if we did that. Page 90 and page 93 of the report seem to be blank. And one of them's demographics. I can't remember what the other one is. And the final point is, bearing in mind what Gail said some time ago, that reviews don't necessarily mean cuts. In terms of the EQIA, can we have confirmation, real confirmation that carers and the cared for will not be disadvantaged by any changes in financial or the review itself?
Peter, I'll deal with the most straightforward one. We don't have any blanks in our report.
All right.
Something's happened with your version.
Page 93, the demographics page is blank on mine.
Yeah. I'm having IT problems myself, so I couldn't save anything. So I'm working from a paper copy, but I have a whole page of demographic pressures followed by support and personal care at 6.2. Have you got that?
No, this is the plan itself, George.
Oh, the plan itself. My apologies.
Page 90.
Yes, he's right. It's the same on mine as demographic pressures and data collection has got nothing underneath it.
Yeah.
Oh. Have you got a page with accommodation on it, Peter?
Yeah, that's blank as well. Page 93.
I think what's happened is it's gone on to the next page.
Yeah, this is a spacing issue in some areas, I think.
Is that what it is? All right.
Yeah, I think it is. It just runs on the next page.
Yeah. I just saw the blank. I thought, oh, it's blank. Nothing there. So okay.
No, but I think you're right about the demographic one, because I know what's happened to that here. It's a technical thing that looks a bit
layered on top of it.
Yeah. Good.
Okay, was that all of your questions?
EQIA and the National Health and Wellbeing outcome number 6.
Peter, I'll address your financial disadvantage. I don't think we can ever say in any policy formulation that nobody would ever be financially disadvantaged, but we have mitigation for those kinds of circumstances through our procedures. I don't think there's anything within this report that would obviously disadvantage anybody, and it's not our intention to do so, but also that's also a matter of interpretation, isn't it, in an individual case. So I wouldn't feel able to give a kind of blanket qualification that nothing in the strategic plan would ever disadvantage any individual. I don't see how we could be expected to do that. Every individual case has to be considered on its merits. No.
I think the thing that concerned me, it was a blanket, ticks in the positive box for everything and everybody. And it just made me wonder whether it was going to be positive for everybody.
Did you have an example, Peter, to help me?
No, I'm sorry. I say it was just I looked down the EQIA and I thought, everything's been ticked as a positive, and I'm not sure. And I know a lot of it will be, and the intention certainly is that it should be. But we've been here before where something pops up and they say, actually, there are individuals who are disadvantaged in this sort of report. So
sometimes we know that, and other times we don't, and it's an unforeseen consequence, but we always work to remedy those, Peter. I'll give you that assurance. We're not in the business of putting people into impossible positions by our policy changes. So
I realise that. Okay.
Yeah. We can have a look at that in more detail offline if you want. Yeah.
Yeah. The final thing was whether we could have health and wellbeing recommendation outcome number 6 at 6.3 for carers.
Well, Peter, you need to remind me what it is.
It's the I'll read it to you, George, because I wrote that down as well. People who provide unpaid care are supported to look after their own health and well-being to reduce any negative impact on their caring role and their own health and well-being. So it's basically saying, we will support carers.
Yes, of course. I'm just taking that as a given, and it also will appear in our carers work, which we report on regularly here. It's in the carers strategic improvement plan as well. So yes, you can have an assurance about that, Peter.
Good. Okay. Right. That's me done. Thank you.
Thank you.
Can we, George? Sorry, can we note that as well for Peter in the report? Yeah. Thank you.
Alison?
I just wanted to highlight the links between social health and the plans here, which are really about providing affordable care for people with physical disability, often at the more advanced stage. But we did have a discussion at our clinical partnership group about the overlap between the physical health and how we can act earlier in people's journeys to support people experiencing physical ill health. And I appreciate some people have sudden events such as a car accident, but a lot of people are younger adults or people living with neurological disability or other disability that's with them for a long time, with carers that are looking after them for a long time. And we've got some exciting work supporting people with MS at an early stage, but early signs are that it's working very well, with specialist nurses aligning with our community nurses. Now, our community nurses are linked into the social care, they're linked into the social prescribers, mental health, aligned within our integrated teams in our community. So we're taking that specialist knowledge with the specialist generalist knowledge in the communities and this real nursing leadership around that. And then we're really keen to keep working at that, identifying how we can support people right from the beginning of their journey with ill health all the way through, so by the time they're needing extensive accommodation or other inputs, we've done the best for people through the whole of their journey, and some of that means that people are able to be cared for in the community for longer, and that is one way that we can help make services sustainable for the future, at the same time supporting people and doing the right thing by people. So I just wanted to highlight that's an example of where we're needing to make changes now, but that as we look to address the wider strategic risk about earlier intervention and prevention, that this is the sort of links that we're making now to try and make things sustainable for the future.
Okay, that's helpful. Thanks very much, Alison. And Chris.
Thank you. Just a couple of points on 6.5 about the Glenloch Centre. I referenced back to the June 2020 report that was mentioned on page 1, and it obviously talks about the existence of the Glenloch Centre. It didn't indicate necessarily that there would need to be a review of the service provided at Glenloch. So I suppose just 3 things really. One, I think we've got into the habit in recent months of perhaps a quick briefing when there's going to be sort of kind of local authority related reviews that could have an impact on staffing. So obviously just caught this as I prepared myself for today reading through the papers. Clarification probably on a couple of things was that in the second line, it says that the review of the Glenloch Centre, etc., may include the reprioritisation of services to better meet the needs of service users. As somebody who isn't a healthcare or social care professional, I was wondering if I could have some clarification on what that reprioritisation means. And secondly, as well, if there's any early thought on if that reprioritisation, whatever that is, happens, what's the impact on the staff that currently work at the Glenloch Centre potentially likely to be? Thank you.
I'll make a general comment, Chris, and then bring Linda in because that's one of her services. Yeah, I mean, I think we have a duty to continually review our services. That's review with a small r, to make sure that they're working efficiently, that we're giving the best possible service to the public, that we're meeting need above all, and that we're providing value for money. That's a statutory duty as well. So I'm seeing that at the moment as a review with a small r, which might and is likely to proceed to a review with a big R, if you like. So when we talk about reprioritisation of service, our uptake isn't that great in Glenloch. There's not that much demand. We're probably, but we think we're not providing the best service for the public. So therefore, we've got to look at the type of service we are providing there. But that is in general terms. I'll bring Linda in. We'll be a bit more specific, I'm sure. Linda?
Yes, Chris, I would say that at this stage we're definitely talking about review with a small r. We've done a lot of work to enhance the service that we've got at Glenloch. You know, talking to referrers, care managers. We've got a change of unit manager there to look at you know, just as much as we can do to enhance that service and make it attractive. And also to tidy up, you know, I don't know, just generally have a refresh of what the priorities are there. Unfortunately, COVID really probably had the major impact for the people who used to or did attend Glenloch, and they've really kind of voted with their feet. They're not keen to return to a building-based service, so therefore a lot of the input that the staff are now providing is as outreach and in people's own homes and communities. And that was also echoed in the engagement feedback that we received. People are looking to be engaged in community opportunities and activities in their own hometowns and not necessarily travel to One Angus. So really that's why it's almost this, you know, currently the staff are reprioritising their activity to not be doing it from a building base. So I think that's where we're at. We're talking about a small review at the moment, but we need to see where that takes us. Yeah, I think that's all I need to say on that.
Well, thanks for the clarification, Linda. And George, small r, big R. There's my lesson for today. Thank you.
Great. Thanks very much, everybody. If we move to the recommendations for this paper, so you have them before you, I think probably just a change to the final one in terms of rather than approving continued funding, noting continued funding for dedicated senior planning officer resource. So are we happy with those recommendations? Yep. Okay, thank you very much. And we'll move on to the next item, which is the learning disability priority improvements. And George, I think I'm handing over to you again.
Yep. So quick bit of context. Again, this is not the whole world of learning disability. It's constrained to the same kind of parameters as I described last time, and there are lots of interfaces with other parts of the learning disability system. Folk will be much more familiar, I think, with the learning disability developments. We've brought lots of reports on this over the years, whereas PD was a relatively new service. This one also has increased in demand in certainly my 7 years in post. I think it started with an £8 million budget, and it's now up to 15 million. So that's reflecting increased demand, but also reflecting the kind of priority that we have given learning disability services and our need in the first couple of years of that time to catch up, I think, with where we wanted to be. So again, just picking out 6 key things. We're looking to have approved the finalised improvement plan and the action plan. Again, I think we would just change the last recommendation to noting the continued resource. Again, the engagement work, the same approach was taken, be easy to read versions for the engagement materials, and determining a future pathway for document approval that would make that process better in the future. Accommodation. We're looking to identify support needs of people in out-of-area placements or in hospitals who require a community placement. And that is challenging work. Personal care and support and care. We need to undertake a mapping exercise and a service needs analysis to establish the best community support for people with autism and complex need. So those two coexisting issues, autism and complex need. Further work around autism, you can see that's quite a big theme here. Explore models of positive behaviour support, and there's training that we need to implement that. The idea being to reduce hospital admissions at the point of breakdown and to achieve better discharges. I suppose receptions into care would be the same, I would add, as well as hospital admissions. Day services, it's been a really challenging time for day services, you know, coming through COVID, all the restrictions that have been involved in that, trying to get things back up and running, the pressure that the constraints have imposed on carers at home, people struggling to manage. And I know that Linda and her staff have been working tirelessly to keep things going and to open up as much as we can. So we've got a general issue about capacity in the learning disability day services. Demand's increasing, the buildings are nearing capacity. So we've got a looming problem in the future. So we need to include that in our review work. Small R review so far, Chris. So that's it, Louis. That's the big ticket things. I did wonder about the recommendation about bringing another report in February 2022. I think the reporting frequency for the LD work is 6 monthly at the moment. We brought lots of reports in LD. It might be worth a discussion in that reporting frequency out a bit now. I don't know. I'd be open to people's views about it. That's it. Thank you.
Okay, thanks very much, George. Do we have any questions or indeed any comments in terms of the regularity of reporting on learning disability improvements going forward? Peter? Oh, I think you're on mute, Peter.
Sorry about that. Thank you. Yeah, thanks both, Emma Jane and George. A couple of comments supporting what you've said on 6.4 on carer age. Just a reminder that in 2011 at the census, 61% of unpaid carers were over 50. And in 2017, the Carers Diary that was run by the Carers Centre, 85% of the respondents were retired, which tells you a tale, I guess, which gives me a great concern, and obviously you as well. In terms of 6.5, accommodation, I'm a bit concerned when I see things like the database. And I know Linda's been working on this for many years over time. I'm wondering what the margin of error is on that database, bearing in mind that the last time we did a survey in Sappold, in the little local charity, of 6 people who we were talking to, 3 said they were on their person was on the housing register and 3 weren't. And one of the 3 who wasn't said, well, she's not on the housing register, but I wanted to live in Carnoustie. So there's obviously a margin of error there, and I'm wondering how flexible the numbers on the database are going to be, because my concern is that at some point, with the elderly, the carers growing older, we're going to be hit with a need for accommodation. I know this is a sort of 20-year plan, but we need to be able to respond fairly quickly on that.
Thanks, Peter. I'll let Linda respond to the data return, if you don't mind, Linda.
Yeah, so Peter, it's challenging for us to obtain that information at times. We do update the accommodation database in April and October, and we share the broad information with our housing colleagues to inform their housing needs analysis. The data that we keep, we're asking people, carers and families, to give us information about their future, the future accommodation needs for the cared for person for the next 12 months, 3 years, 6 years and 9 years. And we're really relying on people providing that. And some people, as you know, just do not want to discuss that and don't really have a plan. And you know, so what I've asked is that we put our best guesstimate down, if people aren't able to give us that information, so that people aren't missed. And we are considering their needs, and if the carer's not at a stage where they're feeling able to think ahead like that, that at least we're trying to do that. So there will be a margin for error, because it is relying on, you know, folk understanding the question and thinking ahead when perhaps they're not keen to do that. And the information that we provide to housing, they're really taking that and extrapolating that for further years, as opposed to necessarily looking at the immediate needs.
I'm just wondering whether we can encourage people carers to complete anticipatory care plans for their people, and then get some data that way. Even if they say, I don't want my person to be accommodated yet, we can look at that and go, yeah, well, at some point they will need it. If you're 85 and they've got a complex disability, they're going to need accommodation probably in the next 5 years, for example, yeah. or sooner.
Yeah. I did have a very positive meeting with a family last week on this subject, and yes, you know, that issue came up. You know, if you're, you know, it is really that whole need, isn't it? It's not just necessarily accommodation one; it's whatever other things might be required in the case of an emergency. So yes, trying again to promote the emergency plans for people. Sorry, I think you'd mentioned something else in your question that you covered, but
I think you've covered it all in there.
Okay.
It was just the demographics of the carer population.
Yes. Yeah. I mean, Peter, we are trying to ask our carers their dates of birth. Don't be offended.
Well, you could say, do you remember pounds, shillings and pence?
Trick questions.
Okay, thanks for that.
Okay, and Councillor Speed.
Yeah, thanks. It was just with regards to bringing back the interim report in February 22. And I just feel that given that we've just agreed on the previous agenda item to bring back an interim report, and that there are some overlaps, it would perhaps be useful to still continue with agreement of that, or keeping that recommendation in there, and then review it again in February.
Yep, I think that's what I was thinking as well. So Sandy, do you want to come in?
Yeah, thanks, Chair. Mine is a general point, not really a question, just a general point regarding both this paper and the last paper. All the members of the board will be able to see the pressures that we are already experiencing in physical disabilities. And in the financial assessment here, you can see that some of the improvement plans that do have a financial impact, you only go so far in terms of covering some of the pressures that we will see in learning disabilities. So there's a significant potential exposure to pressure in both these services. Now, if we assume we have an inflation neutral environment, which would be nice, but if we do, put extra resources into these services over 1, 2 or 3 years, if that becomes something that we do end up doing, means the resources either have to come out of other services, for example, older people or mental health, neither of which is particularly easy to do, of course, or it means we absolutely need to keep focused on the kind of savings planned interventions that we see described in the strategic financial plan. And I absolutely appreciate we've made some difficult decisions in the last 2 or 3 meetings, but those are the types of things that allow us to do various things, such as supporting older people demographic growth, or potentially looking at looking at the kind of exposures we have in these papers. So I just wanted to make sure people were, I know you all will be, but I just want to make sure specifically we're drawing these 2 points together. It's worth bearing in mind that the financial plan that we saw in April, the IGP in April at the time had a £4 million shortfall 2 years from now. So we just need to keep all those things in mind, Chair. I know people will be able to draw that together, but I think it's important we just kind of note that. Thank you.
Thank you, Sandy, and I think that is absolutely worthwhile to draw our attention to. Okay, if we've got no further questions, just moving to the recommendations. I think I tended to agree with Councillor Speed's point in terms of the retaining the report coming back in February and then looking further ahead as to what the reporting periods will be. And again, just that change to the last recommendation in terms of noting the continued funding for a dedicated development officer resource. Everybody happy with those recommendations? Yep. Okay. Thanks very much, George, and to Morgan and Linda as well. Thank you. So if we move on now to item 11, and that's the Angus Igb Audit Committee annual report. Sandy, is that you?
Well, thanks, Chair. I'll kick off, but I'll let Julie add something in a second. Hopefully this report doesn't generate quite as many questions as the last couple of items. So this is our annual report of the work of the Audit Committee. I suppose it's intended to make sure that this board are well cited on all the work, and I think positive work that the Audit Committee has been able to do during the last year. Equally, I hope it gives the Audit Committee members themselves a sense of being able to share the work that they've been involved in. And I say hopefully it does that. The main body of the report, the table that sets out all the activity that's been discussed in meetings, really gives a good example of all the kind of breadth of issues that we're covering, whether it's a cyclical or one-off or an annual nature. So hopefully it does all that. There are some conclusions towards the end. We capture a governance conclusion from the auditors, but we also kind of sum up by the Audit Committee saying we do feel we've fulfilled the remit that we have set. The Audit Committee has a limited remit at the moment. We know that, and it sets that out in the Constitution, but I think we can say we've done what we were asked to do. We've done it well. We've managed to keep on track. Issues obviously to do with COVID at the start of the last financial year. I think personally, obviously, I want to thank all the members of the board who contributed extra time to being on the Audit Committee, including Julie as chair, but all the members who participated throughout this year, because I appreciate it's an additional ask of them all, but it is very much appreciated. Julie, do you want to add something?
Well, you've kind of covered off everything I would have said, Sandy. Thank you. How efficient of you. But no, just, thanks to the members of the Audit Committee. It's quite a vibrant committee, I would say. There's a lot of energy and enthusiasm for audit. That's not a sentence you hear very often. But I find it a committee that I'm really happy to be part of. And I just want to thank everyone for your contributions and to the internal and external auditors as well. And we had a very good session this morning, the discussion at the Audit Committee around risk appetite, which has been, I think, an incredible refresh of where we are, that everyone engaged in really, really well. So welcome to the new member of the Audit Committee. Thanks to the pre-existing ones, and if we have any questions, please refer them to Sandy. Thank you.
Okay, thanks both. On the paper? No. So are we happy with the recommendations within that? Yep. Okay, thanks very much. So moving on, just checking the time, we're at 4:30 now, so just a time check in terms of where we are and where we are in the agenda. Moving on now to the paper 12, which is the Angus Igb partnership working. I think, is this Jill? Yep. Jill, do you want to just highlight just briefly anything particular about this paper?
Yeah, thank you, Chair. Again, similar to the last report, I think it's pretty self-explanatory, and the appendix details the partnership work that we do across a variety of areas. Just to note, in terms of the aims of the groups for Unscheduled Care Board, Planned Care Board and Operational Leadership Team, we do have that up to date now with that information, so any future reports will include that. But happy to take any questions. I think it is, as I say, self-explanatory.
That's great, thanks. I think it's very good actually to be laid out in front of us, the kind of breadth of the partnerships that we're involved in or involved with. Do we have any questions on this? No. Are we happy to note this paper then? Yep. Oh, sorry, I see one hand has just gone up. Catherine?
Sorry, I think my system's running a bit slow, which is why I'm running with my video off today. I just wanted to flag for members' awareness as well that obviously health and social colleagues are also part of protecting people arrangements, and that includes both the adult and child protection committees.
That's great. Thanks, Catherine. Any other questions, comments? No. So happy to note the content of that paper, and then we move on to the number 13, which is the workforce plan annual update. And as if on cue, George, this is you again.
I timed that very quickly as I went out to the gents. So perfect timing. Okay, yeah. So I took over the workforce lead when Bill Troop retired, so probably in May. It's felt like there's been a lot going on with it. Kind of some of that's conveyed in the report. The specific task was to report on the things that were due in August, which are all covered in the appendix. But I took the opportunity to kind of give a more general update on the state of play with workforce. So that really commenced with our EMT on the 30th of April, when I just really wanted to kind of tighten things up a bit on the governance front, and we agreed we would report quarterly to EMT. We would try and combine the various plans that there were, so we had a workforce plan, leadership plan, the remobilisation plans into one workforce document for a bit of clarity. And we wanted to introduce, and credit to Fiona Rennie and the planning team, it was our idea to have a workforce steering group, which would link closely with the staff partnership forum. We haven't quite worked out how those two things are going to connect entirely yet, but we're working on that. And the workforce steering group has now actually met twice, so that's specifically for the health and social care partnership. So the current position, Scottish Government requires that all health and social care partnerships submit a workforce plan by the 31st of March next year, and work's underway to develop that plan. We don't have a standardised format from the government as yet for that, but I expect one in due course. Meantime, NHS Tayside is also required to produce a corporate workforce plan, and we were asked to submit the information for that, not just on the NHS employees of the partnership, but on the whole of the partnership's workforce activity by the 5th of August. That was pretty demanding. We only got asked for that in July, and of course it was peak holiday period, but somehow we managed to do it, and we have made a submission. And it's actually been quite useful for us to be able to kind of kickstart our own partnership workforce plan. And we're due to go to a review meeting about that in September to get some feedback. I think, though, that we need to tighten up on our governance routes for workforce. And for me, the proper arrangements for the partnership are through executive management team and the strategic planning group, the Igb. The strategic planning group, because it's really important that our workforce connects very closely with our strategic plan and with our strategic financial plan. And it's not that, you know, I'm wanting to be uncooperative with any of the parent bodies, but it is that we need a clear kind of arrangement for our own partnership business. And rather than doing everything in triplicate, one side council facing, one side NHS facing. So what else? Yeah, a bit of feedback about the first couple of workforce steering groups. The first one was very much just about setting out our terms of reference and how we were going to do business. But the second one, we began to move into our 6-step methodology to develop a workforce plan. That's the technique that we're using. And we also tabled a draft data set. I don't mean a full one, I mean the actual framework for gathering the data. And we have a lot of work to do on gathering workforce data. But that meeting is going well, I think. And you can see in the report, I've covered that, but also just some of the kind of key headlines around workforce challenges like recruitment to certain posts, the aging nature of our workforce, including the senior managers. That's me, of course, aging, and the impact of COVID and agile working and so on, and some of the things we spoke about today, the state of the frontline staff and their fatigue levels and so on. So just picked out a few highlighting things there, and then just referenced in the appendix. So plenty of financial implications. Everything you do really in workforce has got financial implications. And of course, we've spoken a lot today about increased demand. Those have significant workforce implications. Really across the board, we've got increased demand. So what I've kind of said in the last two paragraphs on section 4, well, sorry, the second and third paragraph, is it just can't be a wish list for ever increasing resources. We need to be smarter than that, because financially we can't do that. And that will involve moving resources, including staff, from pressure points to other pressure points. Is really the only way we can do it, and by moving transfer, disinvesting in some areas to invest in others, and bearing in mind our statutory duties and so on. I think one thing that I'm a bit of a convert to, I guess, is the absolute importance of good communication. I think in the Staff Partnership Forum, we've now got much more in the habit of early sharing of plans. So even when it's a small R, Chris, we want to make sure that yourself and staff side are cited on that. So that's really about it. A general update, and just the submission of the updates on the I think it's 6 tasks that were due for August. Thanks, Chair.
Okay, thanks, George. So see a number of hands up, just mindful of time. So keep questions questions and answers as concise as possible, if that's okay. Councillor Bell.
Thanks, Emma Jane. Thanks, George. Page 168. How is the Healthy Working Lives Award scheme being supported within the IGB? Is it an internal person? Is there a group, or is it through public health team? And obviously vested interest there, because that used to be my job.
I know, I remember that. I remember, sorry, that you used to do that, Julie. Yeah. I think that's primarily been driven through our improvement and development team. I don't really have a lot of detail on it. Julie, can I take that offline and get back to you? Yeah.
Okay, and Gail?
Yeah, I actually want to commend George in his role in taking this on, because this has been a significant piece of work, and none less because of the unanticipated timescale on the 5th of August. This really came out of the blue, because we weren't anticipating this as a health and social care partnership until March of next year. So I would really like to commend George and the team for actually pulling all this significant piece of work together, because it's not been an easy task. So I want to thank George and the team.
Thanks, Gail.
And Charles.
Thank you. Getting my Sunday name, imagine.
It's
okay. Thank you. Again, just to echo Gail's comments, but as I'm on page 166, as George has very correctly mentioned, the Health and Care Staffing Bill will have implications for us going forward. It was originally healthcare, and then it got changed to health and care, so you'll recognise a not so subtle bit there, essentially. The caveat within that act is that there will be tools developed, and they will be multidisciplinary or interdisciplinary, and so we'll go across all our settings. And the only reason I really highlight that is, again, because there will be an expectation that we adopt them, so there will be implications for local services to use them, and that will then be used for our workforce planning going forward. As you said, George has done well, but also just to encourage colleagues and members of the IGB that there's a lot of work within Angus that I've seen coming in, fresh eyes, new eyes, around delegated tasks, around supporting the integration truly of teams. And we've got a lot of really good experience of that and good examples at an operational level. So just to encourage you of that. And again, thank you for being involved in that. It's been good.
Thanks, Charlie.
Thanks.
Thanks for that. Do we have any other questions? No. And are we happy with the recommendations at the start of the paper? Yep. Okay, thanks very much for that one. And moving on now to item 14, which is the Angus and Dundee Stroke Rehabilitation Pathway Review. And I will hand over to Jill.
Thank you, Chair. And thank you again for the opportunity to bring back an update paper on stroke and the rehabilitation pathway that we've been working on jointly with Dundee Health and Social Care Partnership. I am joined by colleagues today that have supported this, so I think Dr Ian Logan's on, Morag Hambleton, Sally Wilson and Jane Moog have all been involved and played a critical part to get us to where we are at the moment. So just to extend thanks to them and the wider project team. The paper sets out the progress that we've made in relation to the review of the and redesign of the stroke rehabilitation pathway. And that is part of the Angus Care model. It was identified as a programme of work prior to the COVID-19 pandemic through the inpatient review. And it does follow on from a lot of the work that has been progressed from an acute stroke perspective. The paper outlines the process that we followed to get to the point of having a preferred option, and we did go into a lot more detail around that process as part of the consultation and engagement programmes that we had running. So we did have a number of sessions, and Sally will talk about the consultation and engagement that we have undertaken. I think it's very important to acknowledge that the preferred option that we've come up with very much sits with the 4 strategic priorities of Angus Health and Social Care Partnership around improving health and wellbeing, independent living, support and care needs at home, and developing integrated and enhanced community care, as well as improving integrated care pathways for priorities of care. The approach that we've taken has been a clinically led approach, but in addition to that, we have taken a different approach in that the involvement of people with a lived experience of stroke have been heavily involved from the start of this piece of work and have informed a lot of the work and the options and the preferred option and the process to get to that. And we've taken it from an approach of we want to provide a person-centred service rather than a facilities-based or premises-based or service-centred approach. And it allows us to address some of the risks around workforce, premises, as well as allowing us to reprioritise and reinvest some of the resources that we can, whilst improving the outcomes for the population of Angus who do unfortunately experience a stroke. I think before I bring others in, Chair, I would just like to draw the board's attention to the risk section of the report, which around if we can't approve today, we will have to continue to provide the services in the way that we're currently doing so, where we are providing inpatient care through RVH and support through the MFE consultants to stroke for individuals who are able to come to the unit in Stracathro. That is going to get a bit more challenging from the end of August because the MFE team don't have the capacity to cover that on a longer term basis. I'm just going to ask Ian and Morag if she's around just to comment from a clinical perspective, and then Sally to give the consultation and engagement that we've undertaken.
Certainly. Hi there, to talk today. Really just to echo what Jill has said is that this option gives us the best opportunity to really develop a service that we should be delivering in Tayside. Many other centres across the country and indeed the rest of the world are already delivering home-based stroke rehabilitation. There's good evidence this is good for patients. It reduces long-term dependence above and beyond what hospital-based rehabilitation does, and the only way we can really deliver this is going to be to sort of look at consolidating the two services onto one site and then freeing up resource that we can then invest back into the community to really make a difference to how we deliver community-based rehabilitation. We don't have that service in Angus. There's a basic form of it, or a sort of an embryonic form of it in Dundee, but they're not achieving what they want to achieve, and we've got nothing on them at the moment. In addition to that, it's not just about developing the service in the community. It's really about trying to meet a standard which nobody in Tayside is achieving in terms of inpatient rehabilitation. We all recognise that the teams who are working in the stroke units up and down Tayside are doing a great job in terms of the quality of the work they provide. The problem is that they're struggling to provide sufficient rehabilitation. We should be really providing rehabilitation to people 7 days a week. And I'll be honest with you, I don't think there's a single centre in Tayside that's doing that. And there are many centres in Tayside, including Angus, where we've been struggling to provide rehabilitation 5 days a week. There's times whenever you can access a speech and language therapist once, maybe twice a week. You might get a speech and language assistant on some of the other days, but none of us are providing the sort of recommended levels of rehabilitation that we should be. So this is, again, another way of taking a step towards doing that. And really with the idea ultimately of reducing long-term disability and dependency. In addition to that, we know that there are going to be significant challenges. There are already challenges within our staffing model, but there are going to be significant challenges coming over the next few years in terms of nursing models, as well as medical and therapy cover. So this is really the only way we can see of actually providing a sustainable service which meets not just inpatient rehab needs, but also sort of gives us an opportunity to develop a model that takes rehab into people's homes and gets them home sooner. I don't know if there's anything more I would like to add at this point.
Thanks, Ian. Yeah, I think it's just really reinforcing what Jill has outlined and Ian has mentioned, and just really to add to what Jill mentioned about those patient voices and how integral they have been to the work that we have done, and how clearly they articulate that they want care to be delivered at home as soon as safely possible, but with the standard quality and intensity of rehab that's required to allow them a transition back into a fulfilled life. And I think that it's something that we've not been able to do, those transitions of care into the community is something that we have that we have difficulty delivering, and this proposal helps us to move towards achieving that. And we know that's what patients want. We know that the staff want to be able to deliver that better community involvement. So it's really just to emphasise the importance of those patient voices.
Thank you, Morag. I think, Chair, if it's okay, just to invite Sally to give an update on the work that we did around the consultation and engagement, because I think that was a really important part of the process that we went through. Sally?
Thank you very much. So I think it's important to say that at the very beginning, we liaised with Healthcare Improvement Scotland Community Engagement to seek guidance as to the proposed communication and engagement activities. And we did acknowledge the fact that there are challenges in our COVID world, that it's really difficult to engage with people, and it's not possible to have the rich face-to-face engagement activities that we had before. And also acknowledge that any engagement activities really needs to be proportionate to the number of people likely to be affected. So we were advised to be really clear about any preferred option and share openly the reasons for this. And we also discussed the need, or we were advised about the need to really consider the potential impacts that any option might have, for example, in relation to travel and access. It's important to say that right at the very beginning, we engaged with Stroke Association Scotland, and they have really been integral to making or helping us make decisions and developing our proposals. And they were involved in the appraisal of options, and they have provided a statement of support for our proposed pathway. Previously, a lot of work had been undertaken with people with lived experience of stroke, and it's very clear, as Ian and Jill and Morag have said, that they want to be at home as soon as possible. And it's that we have to listen, obviously, to what they're saying. So we promoted our engagement activities on Facebook and on our website, and issued a press release for those who didn't have access to that. And within our engagement documents, we provided an opportunity to speak on a one-to-one basis with us via a telephone number, and we encouraged people to share this information if they knew people didn't have access to electronic means. And we conducted a survey monkey, and in fact some people did respond using a paper copy. You might be interested to know that 1,000 people clicked on to the Facebook post, and that means that they actually didn't just skim read it, they actually clicked on for more information. And a lot of people shared the post, and it had a potential, I have to reiterate, potential reach. Facebook is very good with its analytics, had a potential reach of 24,000 people. So about 105 people responded to the Survey Monkey, 43 of whom actually had lived experience of stroke, and we held a number of public say that the majority of people were in favour of providing home-based rehabilitation, and as soon as possible for people with mild or moderate stroke. And where there was concern, and there was concern about the lack of, or it was a perception that the services were being withdrawn from Angus, but in actual fact, as Ian was saying, it's about investing in the services in Angus to enable people to have the best possible life. So I think that's all I need to say. Oh, maybe lastly, we did engage with the Northeast locality, who is perhaps the locality that's going to be most affected by this. And although they too raised concerns about travel, they were supportive of the proposal. So I think I'll close there. Whirlwind tour of our engagement activities.
That's great. Thanks very much to you all. Thanks to Jill and Ian and Morag and Sally. I think there's lots of information included in the paper. There's assurance within the paper and also assurance from Sally in terms of the level of engagement. I know it's good to hear your final points in terms of the Northeast locality in particular. Very helpful for us as an IJB board to have that clinical voice represented as well today. So thank you very much in terms of the support. I think for me, this move to a person-centred model is really key and central to the development, and also that last point about investing in Angus community services as well. And I'm also very mindful of the risks or the particular risk outlined by Jill at the start whenever she was presenting her paper. But I see others have got some perhaps comments, questions. I'll just start with Councillor Miles.
Yes, and I must concur that a home-based rehabilitation is definitely preferable for the mild and moderate strokes. However, when it comes to more serious strokes, I'm a little concerned that the Angus patients might lose out. And I know Sally said there was consultation with those that getting access for relatives and those down to Royal Victoria Hospital. But you also said that there was consultation in the North East locality. There will be quite a number of patients in the South Aberdeenshire cluster that might be looking for something like that as well. So would there be a possibility of keeping a bed or two in, like a Staccato, for the more severe stroke patients that could be monitored on a different type basis? But obviously the mild and moderate strokes, but by all means I would support the view you have there. But it's just we seem to be losing a service, and that is the measure that's going to get, and the measures that's going to get back to especially the elderly in Angus. If they have a severe stroke, they will have to go all the way to Dundee to visit any relative or whatever. And especially the elderly will have a lot of concerns with that. So I do have concerns about that, and I would like to know what the consultation did throw up on that. You said there was consultation. What you didn't say is what they were saying on that. Thank you.
Thank you, Councillor Miles, and I think there is some details of the consultation and the Survey Monkey included in the covering report. In terms of the practicalities of running the two units and maintaining some kind of inpatient facility in the North Angus, it would then mean that our ability to invest additional into the community was less. And I think, and I know that Ian will want to come in around that as well. In terms of the feedback, we have looked at the split of patients who have experienced a stroke over the last 18 months. And it's actually South East that's most affected by stroke. So they've had the most people who have had a stroke. And when you look at the travelling distance between, and actually patient choice, because for individuals who do live in the South, Royal Victoria is by mean in terms of transport and access is easier for relatives, etc., to get to. That doesn't not cognisant of the needs of the individuals from the north. The work, if this was approved, we would have to do a lot of work around how we would actually make this happen, and we have had really good engagement with the third sector around how we can support individuals to travel. But whilst the level of rehabilitation that may be able to be provided in an individual home or an individual's home would very much be based on that individual needs. So it may be that they may only need an inpatient stay for a shortened period of time if we are able to provide more of an intense rehabilitation service within their home. I did say that we were looking to provide a person-centred service rather than a premises or facility centred service, and that's really important because we have to have access to the appropriate facilities, and we do know that in terms of the Stracathro site, it isn't as robust as RVH at the moment, and that is from a health and safety perspective, it's from a fire safety perspective as well, so we needed to take that into account. But the ability to staff two inpatient units and run a home rehabilitation unit would be very challenging in terms of workforce, albeit it is not one of the key drivers for this piece of work. And with Aberdeenshire, there's actually only been one from that area in the unit since, I think it was 2018. So that is a very, very small amount, and we will have to NHS Grampian around that in the partnership, but not a significant number of individuals coming our way. They have a very good stroke rehabilitation unit in Aberdeen that will serve the population of Aberdeen. I don't know, Ian, if there's anything that you want to add around that in terms of the facilities at RVH. I think it is worth noting patient choice as well as the feedback from individuals in RVH has been extremely positive thus far as well. Ian?
It was really just to come in and say, I think I would be very wary about creating a situation in which we're keeping a bed or two just for one or two people, and it's not really properly staffed, and we don't have a reliable workforce, and there's no consultant cover, and you end up with a situation where you're actually, because somebody's had a severe stroke, you're actually offering them a poorer quality of care than they would receive if they went to the Royal Victoria. In the RVH, there are clear links with the acute stroke unit in Ninewells. The consultants who look after it are both working in the acute stroke rehab, the acute stroke unit in Ninewells, as well as stroke rehab. There's good continuity of care. There's better provision of nursing cover, physiotherapy, OT, and speech and language, which would be the sort of the intention with consolidating the service. Once you start trying to keep a bed or two for people just in case, you end up with a shadow of a service which really won't be delivering high quality care. What we've learned from our experience over the last few months is that, yes, whilst the Medicine for the Elderly service has been prepared to sort of provide senior cover on a week by week basis, this has basically been a rolling rota of somebody taking on a week at a time. The continuity of care is non-existent, and that's something that's really important in medicine in general, but in something like stroke rehab, where you're trying to follow somebody up, somebody maybe who, as you say, Councillor Miles, has had a severe their communication, they have problems with swallowing, they're at high risk of getting chest infections, And this is exactly the group of people that need continuity of care. They need to know, you need to know that there's a consultant overseeing that whole process of rehabilitation and medical care, managing things like complex decisions about when are you going to insert a feeding tube into somebody, when are you going to withdraw treatment of care, how are you treating infections, when do you need to escalate somebody's care back to an acute unit like Ninewells, things like assessment of capacity and complex discharge planning. And you cannot do that with a sort of a rolling rota of a different geriatrician dropping in for a week at a time. What we found was that there were people were going to see a patient once and decisions were not going to be made. They were just going to be simply rolled over to the next week for somebody else to decide. You know, it's that classic thing. If you don't have to make a decision, the people say, well, we'll see how they're doing next week and we'll sort of take it from there. And decisions were not going to get made. Really, what we realized was that we could not safely look after, as a team of sort of geriatricians, we could not safely look after complex strokes in the stroke rehab unit in Stracathro. And the result has been that we've had to simply look after those patients in the Royal Victoria for the last few months. In addition to that, as Jill has already alluded to, and I think some of my colleagues have touched on, there are a lot of people who live in South Angus who don't want to travel up to Stracathro. It's a nuisance to get there. It's a nuisance for their families to get there. It takes them further away from home than going to the Royal Victoria. And people living in Carnoustie, Montefieth and Arbroath have by and large chosen to go to the Royal Victoria because it's more convenient for them. I fully recognise that the North East is going to have a challenge in terms of getting down to RVH to visit, and I think there's a real need here to link in with not just sort of the voluntary sector, the third parties, the third sector, but also having conversations with sort of transport links and saying, well, what do we need to do differently? Because you're not going to be running buses to Stracathro for stroke patients, so what do we need to do differently? But I think that the sort of the biggest concern we've had has really been one of safety, in that it's not safe to continue delivering this sort of ad hoc service that we've been kind of propping up for the last sort of 3 or 4 months. And I would say from, you know, that was a service which we said we could sort of provide up until the end of August. From September onwards, that service, the MFE consultants aren't in a position to continue looking after the inpatients in Stracathro. So really from September, there's no consultant cover in Stracathro. So I don't think it's possible to say, well, I know it sounds like it sort of should be a nice thing to do, but it would actually, I think, create more problems in the long run. To have a service like that, it just wouldn't be safe and sustainable.
Yeah, I appreciate your difficulty, but there is a huge catchment area from the south of Aberdeen right to the Forfar area that Stracathro might have been suitable, but it would need a lot of cooperation with South Aberdeen to do that. And money's obviously to go with it. So it was just whether that had been looked at and discussions had been had, because I do know some stroke patients in Lawrence Kirk, for instance, would far rather come to Stracathro than go to Aberdeen. So there is a demand, albeit maybe not as large as I was imagining.
Okay,
thanks. And I think also the ability, sorry, Chair, just to, well, we're speaking about home rehabilitation, we will have a community element to that opportunity to look at a community rehab service within Stracathro, not as an inpatient unit, but just to support a more community-based approach. And that's something that we would absolutely be keen to explore as part of the implementation if the IGB supported this as a preferred model.
Thank you, Julian. That would be welcome.
Thanks, Jill. Okay, so got a couple more hands up. Councillor Bell.
Thanks, Emma Jane. Thanks for the report and for the responses to date. I would just wondered if you could talk a bit more on issues and capacity issues at this stage. How will that service a home-based model, particularly when it's over a wide geographic area? Is there capacity in the current workforce? Would additional training be required? Is there capacity in the wider workforce that maybe doesn't work for us yet but might? What additional pressures might this add to home-based care, including personal care, that might be required until people reach a certain stage of recovery? And has there been any research done on the motivation of people who've had stroke in hospital compared with at home. I'm going from personal experience, because my mother had a stroke a few years ago. Her motivation to engage with rehab got her out of hospital quicker, potentially, because she was desperate to be home. But I think if it was left to her own, left to her motivation at home, having achieved her goal, it might not have been to the same extent. And I just wondered if there had been any research done on that. I fully appreciate and get the home-based care model, but also there are challenges around that.
Thanks, Councillor Bell. In terms of the workforce, I think that I will bring in around that. There absolutely will be a training element. There's no doubt, and what we've ensured that the workforce that we have to support individuals who require home rehabilitation are specialists in stroke, and they have a good knowledge of stroke rehabilitation and the needs of that. I think, as from an overall perspective, Councillor Bell, I think that the service that we've currently got is quite an old service. I don't mean that in terms of the people that are running it, Ian. I'm being nice to you. It is, and we have a real opportunity here to modernise that service. And I think if we modernise it in the right way, we've also then got the potential to attract a different kind of workforce. And there's opportunities to look at how we can support that workforce and give them experience of working within an acute setting from a stroke and rotation into the community. There's the opportunity to explore what Ian was saying around that continuity of care. I mean, this is blue sky thinking, but if you're in hospital and acute and you have rehabilitation there from a physio, wouldn't it be amazing if that went through with you? So you've built up that relationship with the patient. So I think by modeling this, we've got a real opportunity to attract workforce into the service. But Ian, and from their own clinical specialty areas. Ian, do you want to go first and then Morag?
Yeah, thanks. I think there is undoubtedly going to be challenges. There are undoubtedly going to be challenges in actually setting up this service. I mean, I don't think any of us are. I think really the key bit here is looking at what you have across your service, right across Angus and Dundee, looking at what you need, and then really working with your staff, your patients, the families, and the third sector to try and actually develop something that really works for individuals. And I can't tell you what that service looks like because we haven't done that bit of that's a whole other bit of work that needs to be done. So it's not possible to say the service will look like this and this will work perfectly. What's going to work? We have to actually develop that service, but we do it with staff who are actually experts in this and patients who can tell us what works, and then look at the resources that we have and say, well, we've always tied our services to the Stracathra site and the RVH sites, but why are we not using, for example, the Links in Montrose as a centre that we can sort of tap into for the people living in Montrose, or the health centre in Brecon, or indeed in Edzell, and say, look, what can we provide there? What can we do within sort of local, community centres? It doesn't. What we're doing doesn't have to be tied to sort of the traditional base of this is a hospital and this is where we do it. We're completely moving away from that. The other thing I would say is that it's not a case of coming out and saying, right, we've got a fully fledged developed service that is just going to soar and fly. It is literally going to be starting with, this is our first patient and we're going to base it around them, and we're going to gradually build it up, and starting with the very mildest of strokes, the people who probably only need a couple of weeks in hospital. Well, we're going to get them out on day 3 instead, and we're going to do their rehabilitation at home, so they're not stuck in hospital for 2 weeks where they're at an increased risk of getting an infection or delirium, or they miss their family, and saying, right, really this is starting at the very smallest, very most simple sort of levels that we can, and gradually building up. I suspect we'll probably never get to the point where we can deliver really complex rehabilitation for people with, feeding tubes in their own homes, but maybe there's some capacity to do things like that for some people, I don't know, but it really is about starting with the very smallest and just gradually building it up, and that build up is going to take I would say probably months into years. But the only way we can do that is if we make that initial step and actually look at freeing up some resource to actually do that. I think what I would say at the moment is that the patients from Angus who are in the Royal Victoria have been reasonably comfortably accommodated within that model. I don't think there's not a massive backlog of people waiting in the acute beds in Ninewells trying to get in, and everybody's sort of just tearing their hair out and they're all distressed. They've actually managed to accommodate it pretty well. But the next bit is now about trying to reduce that length of stay for the people who are in the Royal Victoria. And so instead of spending 3 to 6 months in hospital, you spend 2 months in hospital, and then you get discharged home when you reach a point where you can be safe at home and people feel confident about you being home. And it's not just families and patients, it's staff as well, and making sure the care package is there to support them. And that's going to take time to get to that point. And undoubtedly in the beginning, it won't really happen. There won't be that immediate traction. It's not like we're going to have the combined units on Monday and by Tuesday we've got a service up and running. It's going to take a while for that to work out. The other thing is, I think you'd asked, Chantabelle, just about this. Was it sort of more about the motivation and the confidence of the patients and their families and the research around it? There is some research. There's quite a bit of research was done a number of years ago looking into sort of home-based stroke rehabilitation, and what they found was that patients are better motivated to do rehabilitation at home because they can see a point of it, they can see a purpose to it, they can see how what they're doing can translate into something real and tangible in their own home, rather than I'm doing this in sort of this very sterile artificial environment where people aren't happy in hospital. I mean, there's very few people I meet who really want to be in hospital for long periods of time. And when you're talking about strokes, you really are looking for some patients 3 to 6 months, if not longer. So I think what we found in the research is that people tend to be better motivated. They tend to have less problems with depression and low mood when they get home-based rehabilitation as opposed to their counterparts who remain in hospital. And the other thing I would say, and I know I mentioned this the last time I spoke to you, was I think we need to view this whole service and the whole system and the process that we have through the lens of a COVID global pandemic. There have been long periods of time in the last 18 months when hospitals have been closed to visitors. And it's not great, but you can live with that if you're in hospital for a couple of weeks with a chest infection and you only need 2 weeks of rehab. If you're spending 6 months in hospital and you get hardly any time where relatives are allowed to come in and see you and you get visitors, I cannot imagine how absolutely heartbreaking that must be for people and how demoralizing and demotivating it must be to not be able to see your relatives, your loved ones face to face, and how difficult it must be for them to not see the progress that you're making face to face, to have to look at somebody through a screen and try and figure out, how is mum going to live at home? How am I going to live with her? My husband or my wife, how am I going to do this? And it must be absolutely heartbreaking. And I think there's an opportunity. I don't see COVID going away anytime soon. This is the way we're going to work and live for, cynically, possibly the rest of my career. I don't know, but there has to be some sort of shift in how we're delivering care to people in hospital. And for stroke patients who are 3 to 6 months in hospital, the only way I can see of actually making this tolerable for them is to deliver home-based rehabilitation. And I think there's an opportunity to really do something fantastic here.
Brilliant. Thanks, Ian.
Thanks very much for that, Ian. I'm just mindful of time. I see we've got Elaine and Gail would like to come in before we look at the recommendations for this paper. So Elaine?
Okay, I will be brief. I know there's a huge amount of work has gone into this, and I was involved in a lot of this because I was the Associate Medical Director with oversight for brain injury rehab. That really is probably my question, and it's probably almost asking if that's the next commission. Looking at the paper, the stroke, some of the stroke unit now is combined with the brain injury rehab unit, and the stroke unit have combined. But I think it's probably also being very mindful about the next step almost in this work, which has been a huge amount of work, is scoping out the needs of people with acquired brain injury that's not caused by stroke, neurosurgery, by trauma. We've probably had slight respite through some of COVID because there's been less head injury, less trauma has occurred because people haven't been moving about. But I think that is something that needs to be the next step, and that I think is working across the entirety of Tayside. And I'm just reflecting there, a lot of that work about whole system, but we need to look what the model is for patients with acquired brain injury as a very subtle background, we tried to, we had 2 consultants and a specialty doctor. It is incredibly fragile sometimes maintaining medical staff. We lost those doctors within 6 months through a variety of reasons, and it was impossible to recruit. Locums, again, this has been we were going through this, Jill and I were on calls many a day trying to find locums, and it is impossible. We just can't get high quality care. So it's really just an ask, really, is that the next step, is the commissioning in this way? But it has to be probably between Angus, Dundee and Perth, of how we commission that care for non-stroke brain injury.
Thanks, Elaine, and Morag's just confirmed with me that there is a separate review ongoing into the acquired brain injury as well.
And Gail?
Yeah, I'll start with my experience here, folks. In the year 2000, I commissioned the stroke unit at Stracathro, the stroke rehabilitation unit. From 2016, I was the lead clinician for the Managed Clinical Network for Stroke. And in 2016, my father had a really dense stroke. So I can speak from immense experience, and I'm a resident of the northeast of Angus. At the moment, I feel that this is really visionary. And I think it would be absolutely excellent if we can deliver this service from home. My main concern is 23 hours of the day, it's nursing staff that are required to support this. So Ian, you're absolutely right. We really need to get the model right and that support right at home from the outset, because we've said it's activities of daily living, the showering, the personal care that is the priority within that first week. People can't mobilise, they can't go to the shower, they've got issues with their bladders, etc. So we absolutely need to get that model of care right. No offence, Morag, but the rehabilitation is a short period of that initial week, but we really need to focus our energies on what's needed in that first week to 10 days. And as Ian says, I really think we have been very visionary here on how we can develop the model and make something extremely positive to meet the needs of the population. He's absolutely right. People do far better at home environment if they're supported, and they're supported by families and friends, and remaining in hospital without that support. I think I would have been distraught if I thought my father was there without our support. I really would have. So I think I really plea that we encourage the team to develop this model and take it forward. Morag, I think you could maybe assure the team regarding rehabilitation and the recruitment of allied health professions, because that has also been a challenge, not just the medical workforce. I think it's very much been AHPs, and I think, Morag, you've got a plan in place there to ensure that we get additional staff to support that. The last thing I would want to do is support care at home and we don't have the services. In addition to that, I'm also working with Angus Council and Angus Alive, and are there opportunities that we can do with physical activity? And as Ian says, perhaps in local health centres, but perhaps also in sports centres as people mobilise and improve that. And Morag herself's involved, along with some of my colleagues, around how we could really take that forward in the future as well. It doesn't necessarily always need to be a health premises. So I think there's lots of opportunities to progress this as well. And I really want to ensure everybody that this is not a financial situation. This is not about saving money. This is about providing the right care for people.
That's really good. Thanks very much, Gail. Morag, did you just want to come in on Gail's point there?
Yeah, thanks. Just on Gail's point and on the back of what Ian was articulating, I think we do. It's just really to reassure the group that we have a cohort of staff working within Angus who have
specific stroke rehab experience who have been involved in the care of patients within the stroke unit. And we have a skill set and a knowledge base across our HP services of people who have a specific interest within this. We also have opportunity, as Ian has mentioned, to enhance the knowledge and skill set of our rehab staff, both not just across acute and rehab, but also potentially through rehab in the community in terms of staff that we would be able to rotate. You know, we can bring forward conversations about rotating staff through those rehab units so that we can enhance that continuity of care. The staff really are really supportive of this. When we spoke to the staff before Christmas about what they felt would be helpful, that timely access to supported and better stroke specific care at home was something that was identified, which kind of helped lead us down the path that we went. So I think the desire, the drive is there to make this better for patients when they do get home, to help those transitions. But we do have a skill set of staff. There is no doubt there are challenges in terms of the geography of Angus and the practicality of delivering that. But the only way that, you know, has been articulated, the only way that we can begin to look at investment in those community-based services is really to look at what that patient journey looks like and the potential that Royal Victoria, you know, gives us in terms of being able to deliver that. And just a very quick word, if I can, to Councillor Bell, just about the motivation that you were saying about your mum, and that's something that we see right across the piece. And I think my hope would be that actually at the minute people transition to home and get very little input, and actually that doesn't help from a motivational perspective, but the anticipation with that extra support at home to help motivate them in their own environment and their own surroundings is something that's going to be beneficial. And as when I spoke at CPG, one of the North East GPs had articulated that actually they've had a case where, you know, patients have been at home and actually the families are there with the patient, the stroke patients, and they want to help, they want to do more, where they have that ability. And so being able to support them as well and our input at home I would hope would only continue to help motivate patients with that extra input at home, rather than them feeling like they've just been left to flounder. Once they've achieved it and they've got home, we want to be able to do more to allow them to live that fulfilled life. And I feel that we really do have the skill set to be able to do that, but a lot of planning to make it happen, but a lot of skill set and desire and drive to want to make it happen for the Angus patients and Dundee patients. Okay, thanks very much for that, Morag. Move to the recommendations now. Do we have, Jill, I see your hand up. Is that a sort of a last word to come in, or?
If that's okay, Chair, and I will be very quick. I think it's just to give assurance to the board around the implementation plan, and that it won't just be around the health and social care partnership, engage with housing colleagues, as well as our social work OT colleagues, equipment, and good point raised around the discussion with transport around the link. So I think just to give assurance that key stakeholder of a detailed implementation plan, and there will also be a workforce plan developed to support that should it be approved.
That's great, thanks for that. Well, I think we've had a thorough discussion around this. There's been a lot of questions and a lot of answers as well, and a lot of assurance provided to us as IJB members. If we move now to the recommendations in the paper, which are to note the work to date to progress the development of the stroke rehabilitation pathway review, to support and approve the preferred model of care, and to note that an implementation plan will be developed and progress monitored by the Angus HSCB Executive Management Team. Are we happy with these recommendations?
Chair,
Yes.
if I could just say on the last point, when might we get feedback on the progress?
Jill, do you have an answer for Councillor Miles?
I would be happy to bring an update report back probably early next year, maybe February next year. That would give us time to work up the implementation plan.
Okay, thank you.
Okay, thanks for that. So we happy with the recommendation, and then to note obviously that this report will come in February next year based on the progress with the implementation plan. We happy with those recommendations? Yes, that's great. Thank you very much, everybody. And thank you, Jill, Ian and Morag as well, and Sally, and for I'm sure there's many more involved in the implementation of this and the development of the paper. So thank you to you all. Moving now to the final agenda item, which is the date of the next meeting, which is the 27th of October. Thank you very much to everybody today for all your input, all your questions and comments, and stay safe, and we look forward to seeing you on the 27th of October. Thank you.